Hello, everyone. Good morning, good evening, or probably good afternoon, depends on where you are. Welcome to join our combined seminar. This seminar is powered by three societies, and they are Arthroplasty Society in Asia, AAHKS, American Association of Hip and Knee Surgeons, and the CCOS, Chinese College of Orthopedic Surgeons. So today we are discuss about leg length discrepancy and stability. We have great topics and we have great speakers here. So please feel free to ask questions. I'm pretty sure you'll enjoy this seminar in this morning. So let's welcome the founding father of Asia, Professor Wang Yan, to give his opening speech.
Good morning, distinguished colleagues, ladies and gentlemen. It's a great pleasure for me to extend the warmly welcome and a greeting to you on behalf of Asia. The Arthroplasty Society in Asia is a founding chapter. I'm more than happy to see the international organizations and the societies that focus on joint surgery interface with each other by holding such seminar. This co-branded seminar welcome a team of highly regarded faculty from China, South Korea, Singapore, and United States physicians. It's our honor to have our Asia faculty, Mako, who's president of Asia, and Professor Joe, Professor Lin, Professor John, Professor He, and Professor Tang, and also the AAHKS faculty, Professor Kennedy, Professor Slover, Professor Bini, and Professor Schwarzwald. This is today. We will deliver more than 3 hours content on the topic of the leg length, discrepancy, and stability. Aside from didactic lecture, we will have the live streamed case and panel discussion in this seminar. For participants, I believe that case sharing and discuss would be the valuable experience for you and all. I personally looking for a very extensive and successful discussion. Thank you.
Thank you, Professor Wen. Our first session will have 3 topics. The speakers are personally online, and they are Professor Senyu Lin, Professor Lin, and they are Professor Ren Schwarzkopf. The third speaker is Dr. Corey Callendine. Thank you for being with us, especially in Thanksgiving. So Thanksgiving is for family union. So probably we are a part of your family. Thank you very much. We'll play all the 3 videos and we'll start our panel discussion.
Hello, I'm Seung-jae Lim from Samsung Medical Center, Seoul, Korea. Today, I'd like to talk about leg lengthening, a potential risk factor for iliopsoas impingement after total hip arthroplasty. These are my brief CV and conflicts of interest. Iliopsoas tendon, iliopsoas muscle is a conjoined structure of 2 muscles, psoas major and iliacus. It inserts on the lesser trochanter of the femur and acts as a primary hip flexor. Iliopsoas tendinopathy is a poorly understood and frequently under-recognized cause of growing pain after total hip arthroplasty. Patients often have no pain with ambulation, but complain of typically anterior groin pain while ascending chairs, changing clothes, or getting in or out of the car. The diagnosis of iliopsoas tendinopathy is generally made based on patient history and physical examinations. The pain is usually reproduced with active SLR and aggravated with resisted SLR. Ultrasound, CT, and metal artifacts reduction sequence MRI can be used to identify pathologic conditions around the iliopsoas tendon, but negative findings are frequent. Many researchers have reported sporadic case series of iliopsoas tendinopathy after total hip arthroplasty. The incidence is reported to be between 0.4 and 8.3%, but most studies are limited by a small number of patients. Some researchers reported a possible impingement between the tendon and the prominent implant, mostly considered the result of anterior cup overhang. In 2003, Catherine et al. Reported anterior cup overhang more than 12 millimeter is related to iliopsoas impingement after total hip arthroplasty in their 8 cases. Japanese researchers also suggested axial protrusion of more than 12 millimeter and sagittal protrusion of more than 4 millimeter could be independent predictors of symptomatic iliopsoas impingement. However, some patients have complained of persistent groin pain after total hip arthroplasty without a clear mechanical source of impingement. Some researchers suspected increased hip offset or leg length after total hip arthroplasty as a plausible cause of iliopsoas tendinopathy, but there has been no large-scale case control study reporting on iliopsoas tendinopathy. In 2002, Larry Dole suggested that an increase of hip offset or leg length more than 1 centimeter could cause tendon irritation in his one case report. This year publication from UK suggested that iliopsoas tendinopathy is more common in young leg protest or DDH patients because of higher risk of increased tendon tension of iliopsoas tendon after total hip arthroplasty. In contrast to previous studies, we focused on the change in direction and tension of iliopsoas tendon after total hip arthroplasty. To estimate these factors, changes in hip offset and leg length was calculated using pre-op and post-operative radiographs. Some of these patients have taken MRI to check the length and excursion of iliopsoas tendon. But the purpose of this study is to report incidence, risk factors, and treatment outcomes of symptomatic iliopsoas tendinopathy following primary total hip arthroplasty. We focused on changing tension of iliopsoas tendon by calculating changes in hip offset and leg length. We reviewed the primary total hip arthroplasty performed by a single surgeon between January 2012 and May 2018. The minimum follow-up was 1 year. Of this, patients who had iliopsoas tendinopathy during total hip arthroplasty were excluded, and other than Bangkok system or incomplete data, major complication patient was also excluded. So a total of 1,602 total hip arthroplasty enrolled in the final analysis. Our surgical approach was modified Watson-Jones approach in all patients. We only included the patient who received the Bangkok system from Korea and Delta ceramic on ceramic bearing from Germany to reduce confounding factors. Following criteria were used to diagnose iliopsoas tendinopathy. Number one is anterior groin pain lasting more than 3 months. Number 2 is pain triggered by daily activities with hip flexion. Number 3 is pain reproduced by active SLR and aggravated by resisted SLR. And number 4 is no evidence of infection, fracture, instability, or loosening. curve inclination, anteversion angles, and the amount of cup prominence were measured. To estimate in leg length and offset by total rib arthroplasty, changes in teardrop to lesser trochanter distance were measured. Changes in horizontal TLD was considered a change in hip offset, and the change in vertical TLD was considered a change in leg length. Characteristics were compared between the ITP and non-ITP groups. Multivariate logistic regression analysis were performed to find independent risk factors for iliopsoas tendinopathy. Here are the results. The incidence of symptomatic iliopsoas tendinopathy was 3.3% out of 1,602 hips. The mean onset of symptom was 9.3 months after total rib arthroplasty, and 91.3% of the patient who checked MRI showed acute angulation of the tendon in the sagittal imaging. The ITP group was older, had more females, had higher BMI, and had more osteoarthritis. Smaller femoral stem were used in the IPT group, but there was no difference in cup size, head size, and head length between the two groups. More cup prominence and leg length were found in the IPT group. The mean difference in leg length was 3 centimeters. There was no difference in inclination, anteversion, and hip offset change. In our multivariate analysis, female gender, higher BMI, cup prominence, and increased leg length remained as independent risk factors for symptomatic iliopsoas tendinopathy. Let me see some cases. Case one is a 50-year-old woman acquired 8 millimeters lengthening after total rib arthroplasty. She had persistent groin pain after total rib arthroplasty. There was no cup prominence on lateral radiographs. A sagittal MRI showed acute angulation of iliopsoas tendon around the iliopectineal prominence. She underwent arthroscopic iliopsoas tenotomy and has been free of symptom afterwards. Case 2 is a 55-year-old woman acquired 19 millimeter lengthening after bilateral total rib arthroplasty and had persistent pain on her right groin area. The amount of lengthening was similar, but she had no pain on her left side. There was no cup prominence on lateral radiographs. Sagittal MRI showed lengthening and acute angulation of iliopsoas tendon around iliopectineal eminence. She also underwent arthroscopic iliopsoas tenotomy and has been free of symptom afterwards. The number 3 is a 64-year-old woman who underwent bilateral total rib arthroplasty due to hip dysplasia. She got 8 millimeter lengthening on her right hip and 11 millimeter on her left hip. She experienced anterior groin pain in both sides after total rib arthroplasty. Both cups were not prominent on lateral radiographs. This is right hip, and this is a left hip. Right side pain was completely resolved after arthroscopic iliopsoas tenotomy, but left side pain partially resolved after arthroscopic iliopsoas tenotomy. In our 53 patients of iliopsoas tendinopathy, 11 patients underwent arthroscopic surgery. After tenotomy, 9 showed complete remission and 2 had partial improvement of symptom, whereas only 35% had improvement of symptoms in non-operative treatment group. Bell et al. From Portland, United States, reported pain resolution in 93.3% of patients after endoscopic iliopsoas tenotomy for iliopsoas impingement patient after total rib arthroplasty. All right, in summary, The incidence of symptomatic iliopsoas tendinopathy was 3.3% after total rib arthroplasty in our series. Our findings suggested that leg lengthening after total rib arthroplasty can be associated with persistent growing pain caused by iliopsoas tendinopathy, and more attention may be needed for female and higher BMI patient and cup protrusion patient. Arthroscopic iliopsoas tenotomy was effective in relieving pain caused by iliopsoas tendinopathy following total rib arthroplasty. Thank you for your attention.
Thank you. It's a pleasure being here and speaking in this meeting. It's the only shame that I'm not there in person due to the situation. I would love in the next opportunity to come and present my work in person and enjoy the beautiful Congress. Today I'm going to speak about how do I work up the hip spine in total hip arthroplasty patients. My name is Ran Schwarzkopf. I'm a professor of orthopedic surgery at NYU Langone Orthopedic Hospital in New York City. My disclosures are in this slide, and it can also be found in the AOS website. So why do total hip arthroplasties dislocate? We all know that surgical approach, femoral version, leg length and offset, hip impingement, acetabular version, as well as what's in the last 5-6 years we've been talking a lot about, and we'll talk today about pelvic tilt and the pelvic spine hip relationship. So the goals of the presentation is to keep everyone awake because this is a complex subject. Try and make it simple and limit the amount of measurements. Whoever feels comfortable and understands a little bit, I do recommend to look at a lot of the work that Professor Larry Dorr did, who passed away this year, who was a pioneer not only in arthroplasty and hip and knee, but also in the hip spine. And this is one of his last papers looking at the complex relationship of the hip spine and the femur. So how do we get to this work? So we started looking together, me and my colleagues at NYU, at the different spine databases. So we started with the scoliosis database and we looked at 139 total hip arthroplasties in 109 patients, and we found that patients with spinal deformity had an 8% risk of dislocation versus the control group that only had 1.5. So this intrigued us and we decided to look at a bigger database. So we took our Medicare database that represents patients above age 65 in the United States between 2005 and 2012, almost 15,000 patients, and we quantified the amount of spinal fusion and levels they had fused with the risk of dislocation. And we saw as they had more spine levels fused, especially when the pelvis was fused to the lumbar spine, you can see how the risk of dislocation grew from 1.5 to 3 to over 4%. So our goal of the workup, after we know that patients with spinal deformity and spinal fusion have a higher risk of dislocation, is how do we identify these patients and how do we decide what to do different in the operation. So the two main things we want to identify in our patients: do they have a spinal deformity, yes or no? And are they have a spine that's stiff? Do they have spinal stiffness, yes or no? That is the main goal of the workup. So what is the workup? The basic two radiographs are a standing lateral and a sitting lateral. The two lines that we want to place on the x-rays are the anterior pelvic plane and the sacral slope. As you can see here in green, the anterior pelvic plane and the functional pelvic plane. The difference between the two, and we'll talk about it a lot, the anterior pelvic plane is an anatomical plane based on the anterior superior iliac spine and the pubic symphysis, represented here in yellow. You can see the image on the left, it is perpendicular to the ground, and the image on the right, when the patient sits, you can see how the anterior pelvic plane shifts with the motion of the pelvis. The functional pelvis plane is always a perpendicular line to the ground, and that represents the functional position of the pelvis in relation to motion or to the activity the patient does. The second line is the sacral slope. You can see here the normal motion in the flexible spine of a patient with a sacral slope. You can see how the sacral slope changes between standing and sitting as the pelvis rolls into a sitting position. You can see here again the sacral slope and the motion of the sacral slope. And this is the key measurement, or the key thing we have to pay attention in the patients that have stiff and fused spines. So the anterior pelvic plane, we have a neutral pelvic plane We have an anterior tilt, which we say that this is a more standing position. And we have a posterior tilt, which represents a little bit more a sitting position in a normal mobile spine. And you can see you have the examples of good posture, anterior pelvic tilt posture, and posterior pelvic tilt posture. And all this in relation to that perpendicular line to the ground, the functional plane of our ambulation and our motion. So why is all this so important? We know that the pelvis and its association to acetabulum can be oriented in many different positions. And the position of the acetabulum affects the stability of the hip, and the position of the pelvis influences the impingement area that the greater toe can impinge on bone, or the implant can impinge on implant in the pelvis and cause the dislocations. These positions are unique because every bony pelvis is a little bit different. The functional positions of the pelvis are different, as well as the spinopelvic interactions. And we're going to pay a little bit more attention to that. What is acetabular anteversion? Acetabular anteversion is used to describe the orientation of the acetabulum within the pelvis. When we operate, the acetabular anteversion is the angle between the long axis of the body and the acetabular axis as it's projected on the sagittal plane. In the past, we talked about a safe zone from 5 to 25 degrees of anteversion, but today, as we advance with our knowledge, we think and support an anteversion angle of much higher, between 20 and 30 is a more safer zone for most patients. As we increase the acetabular anteversion, it decreases the extension and can result in posterior impingement as we have more anteversion. As we decrease acetabular anteversion, we can decrease flexion, we can increase the extension of the hip, but that can result in anterior impingement and posterior dislocation. And now I'll explain those points a little bit better. Every hip has a mobility cone, an area of safety before you get implant on implant impingement or hip impingement from the greater trochanter onto the pelvis. Every patient, as you can see, has a different position of their pelvis. With the different position of the pelvis, the cone of mobility changes and can lead to dislocation and impingement if we don't take that into account when we do the total hip arthroplasty. As the pelvic compensates and goes into a sitting position, you can see it opens the cone with more motion anteriorly and less motion in the back, because that's the position of our hip flexion when we sit. And when we stand up, we want to move our motion in a position that allows us to extend the hip more so we don't impinge on the back. So if you think about positional changes, and you can see here the images on the right, you can see a normal standing position and below it a normal sitting position. You can see how the pelvic tilts, and you can see how the acetabulum increases its anteversion by that opening the area in the front to avoid impingement and protecting the femoral head in the back to avoid dislocation of the femoral head. We know that every 1 degree of pelvic tilt causes a 0.8 degrees of anteversion and a 0.3 degrees of inclination. The effect on the anteversion is much larger. That's why most of our attention when discussing the hip spine is on anteversion and not so much in inclination. Inclination may be important in oblique deformities in the coronal plane, but most of our talk today is talking about the sagittal plane. You can see the images on the right again, the standing to the sitting and the motion of the acetabulum. So let's give some basic definition. If we think about a rigid balanced spine, that means a spine that's stiff either from surgery or from arthritis and it's stiff in a position of normal standing. So the hip is stable in positions of walking, lying down, and pivoting in a standing position. When the patient goes to sit, image on the right in the picture, the pelvis does not tilt. So at this point, when the patient flexes his hip or leans forward to get up, the femur can impinge in the front and cause the head to dislocate posteriorly. In order to avoid this, and we'll talk about it, adding some more anteversion to the initial position of the acetabulum may protect from impingement and from dislocation. And this is an example of a patient. He has spinal fusion, and you can see there's no change in the sacral slope from standing to sitting. What about a rigid unbalance? Again, this could be rigid and stiff either from surgery or from osteoarthritis. But again, this patient in the unbalanced position which we can describe it as a sitting position. This patient will be safe during sitting if we position the implants in an anatomical position, because it will be open in the front, but it will be protected in the back. But what happens when this patient stands up? When he stands up, his acetabulum is anteverted too much for a standing position. And that's why when he pivots on the leg, or when he lies down and turns to the side, he can cause posterior impingement of his implant and anterior dislocation. And let's look a little bit on the X-rays, because we said this is part of the diagnosis. You can see here how an inlet and outlet view can be affected by the position of the spine. Same thing here, a patient that has a fuse and has an outlet view, or a patient that has a lot of pelvic tilt and has an inlet view. And you can see here the same patient in different positions. So every patient has its own position, and when we see an X-ray, when we evaluate a patient and we get an inlet or an outlet view of the pelvis, we need to start thinking that this patient may have some deformity or rigidity within their spine, especially if we see hardware there as well. You can see here the same implant, you can see that acetabular cup is in a different functional position for each one of these anatomical functional positions of the pelvis. So if the patient is fused or rigid in one of these positions, it affects the functional position of his acetabular cup. So spinal deformity, how do we diagnose? Step 1, standing AP pelvis. This is the functional zone of the patient. And some patients, the supine and standing are not the same. We recommend getting a standing AP. And then we can look here, you can see the difference between a supine and a standing position. You can see that acetabulum for the same patient is in a different position depending on supine and standing. And we want to take into account the functional position of the patient, which is the standing position. And then we want to take the lateral view. We want to see the anterior pelvic plane compared to the functional pelvic plane of this patient. You can see different patients can have different positions of their pelvis. And this is how the patient functions, stands, and ambulates. We do think that a lot of the anterior tilt, like in this image, could be due to femoral flexion contraction, and some of this does get corrected with the toe hip arthroplasty. We want to be careful of some patients that you see these posterior tilts, and you can see that there's a difference between the anterior pelvic plane and the functional plane. And you can see here that if you put the cup in 40 and 20 anatomically, you will get 38 degrees of anteversion, which may be too much for this patient, cause instability. And that's why the plan should be to the functional plane, doing a 40-20 for the functional plane, which would translate into a 35 and 2 degrees for the anatomical plane. You have to remember that we operate to the anatomy, to the anatomical plane, but we need to calculate and plan to that functional plane of the patient. A little bit more advanced concept, pelvic incidence and lumbar lordosis mismatch. These are more complex patients that increase the complexity of the planning. If the PI to LL mismatch is more than 10 degrees, these are a flat back deformity, and the area of stability of positioning these implants are small for these patients. We want to compare standing to sitting. And if we see less than 10 degrees of change in the sacral slope between standing and sitting, this is a rigid spine. And this spine is not compensating or changing between the two positions. And we have to take that in account how we plan to put the cuff. If it moves more than 10 degrees, we do not consider it stiff. So we talked about instrumental fusion in S1 that usually leads to stiffness in patients. More advanced concept, I personally don't do this anymore in my practice, the getting up. It's hard to make it unified between patient, but this is an X-ray that gives a lot of information on that motion most at risk of anterior impingement and posterior dislocation. We have advanced technology. I work with one of my partners, Dr. Poor, to develop algorithms and computer modeling of impingement, and I think some of this could be integrated in future robotic technology. All of my patients get categorized into high risk, intermediate risk, and low risk. High risk and intermediate risk necessitate different planning for their surgery. When I consider planning, it means high offset stems, larger head, and paying attention to their hip and spine. Each one of my patients gets classified as 1A, 1B, 2A, 2B. 2B are the most severe cases where the hardest it is to hit the target and keep these patients stable. We have published, me and Dr. Vigdorchik, one of my partners, many publications, and this is as well in the British Bone and Joint Journal. Every one of my patients, I plan to their functional anteversion and functional inclination goal, and I use this formula to translate into anatomic anteversion and anatomic inclination, which these numbers I use for my robotic or navigation cases in order to hit the goal of where I want to put the cup in these patients. A quick review of a case. You can see this is a case that has normal alignment, normal mobility, and we can see the planning, the anatomic, and the functional are very, very similar in standing and sitting, 20, 22, and 38. When cases are more complex, when we have stiff spines, the angles change. As you can see here, 21 can change to 30, and we have to plan differently for these patients, the fused patients and the stiff patients. And again, you can see here the anatomic plane of the anteversion is 30, but the functional is only 19 because that's what we planned. So much more anteversion to compensate for this stiff spine that doesn't move. You can see stiff spine impingement. You can see here two different cases. And you can see the case as a spine is a pelvic is in a different position. The hip impinges much earlier because there's no compensation. You can see here on the right, that's stuck standing, and the impingement happens much earlier than it happens when the pelvic compensates. So even a 40-20 degree can lead to impingement when the spine is stiff and the pelvis does not move. Different navigation systems like this, you can see you're planning 40 and 20, and I can see that it's this unsafe for the stiff patient when he sits down. I play with the angles. I get now he's safe sitting, but he's not safe standing. Again, safe standing, not safe sitting. And at the end, I get to a functional inclination of 40 and anteversion of 30 to give this patient proper stability due to his stiff spine. His sacral slope does not change, 37, also in standing and sitting. So to conclude my presentation, the main goals here is to work up the patients with proper x-rays. The basic x-rays is an AP of the pelvis, and then a standing and sitting lateral x-rays, which will show us the motion of the spine. And with that, to calculate and plan your surgery based on the patient's functional pelvic position. I want to thank the organizers for inviting me. It was a pleasure joining the Congress. I hope next year we can join it in person. Thank you very much and have a great day.
Thank you so much for having me. It's a real honor and a privilege to be with you all. I'm thankful to represent AAHKS, our American society, and it's good to be with our international colleagues from Asia and CCOS. So thank you for the invitation. My assigned topic today is robotics, the end of leg length inequality and instability. And over the next few minutes, I hope to lay out what's going on in robotics for total hip here in the U.S. These are my disclosures. I am a paid consultant for Stryker, and they promote a robotic system here in the U.S. called Mako. I sit on the medical advisory board for Avail, which is a procedural telemedicine company. I have an equity stake in the ASC here in the U.S., and I sit on several editorial boards. As we discuss robotics, and specifically the literature around Mako, where I am conflicted, I'll make sure that that's clearly noted in my talk, that we only discuss peer review, and that it's noted to be the Mako system. First, we want to recognize the areas for improvement in hip replacement. I want to go through and define the term robotics and robotic assisted as it pertains to hip replacement. And I'd like to describe the workflow for robotic assisted hip replacement cases. You know, it was actually an academic here in the US that really framed my thought process around this. He discussed the evolution of every industry being in these 5 phases. That first it would start as an art, and then it would grow to develop instruments, and then standardized procedures and templates. Perhaps that's where we rest now, but ultimately every industry will evolve into automation and computer integration. Improved patient outcomes are mandatory to justify any additional surgical time, and certainly the education and integration of any new technology into our surgical workflow, as well as absorb that direct cost. So I want to lay the groundwork that that's what we should be focused on as we discuss the literature in this topic today. So robotics for total hip replacement. Total hip was called by Lancet in 2007 the operation of the century. Hip replacement works, and it works well. But there are still failures, and those failures are for several known causes. One is infection, of course, aseptic loosening, wear and metallosis, fracture, and even instability. We'll talk a lot about that today. An instability episode can be quite expensive here in the US, but also very uncomfortable and painful for the patient. Here in the US, the most common cause of litigation is actually leg length inequality, and we'll talk a lot about that today. We know that the rates of hip and knee replacement are increasing. These are US numbers. So what is robotics? I think it's tempting when we say robots or robotics to think about these humanoid type robots. It was actually Da Vinci that developed the first functional robot in 1495. This functional robot has since been recreated and can sit and stand and raise its visor. Or perhaps you think about the Osimo robot that can even play soccer nowadays, or perhaps a futuristic humanoid robot. But that's not really what we're talking about when we talk about robotics around hip and knee replacement. It's really this definition of robotics that I've come to understand the best. Robotics really is an intelligent connection of perception to action, and that's what we're going to talk about. So what are the elements of a robotic system, specifically in joint replacement? Well, first of all, there are several ways to look at systems, and you can look at them in this way very simply. They're either image-based or imageless. So do they require a preoperative imaging study or not? They can be passive, active, or even semi-active. You know, the passive robot here in the States is the Da Vinci that is not really in the orthopedic world. Active is really more like the Think Surgical robotic system. And then semi-active, many of them fall in this haptic protection envelope. But really, this is the three critical elements of robotics. How does the robotic platform handle these three time points, if you will? The preoperative evaluation, is it done with imaging? How is planning done? Intraoperatively, what does the workflow look like? How do you make adjustments? And what implants are selected and when? And ultimately, it's about execution. Is it a conventional saw that's used, or a mounted cutting jig, or is it somehow just guiding you with more conventional instruments? All of these three questions are important as you discuss and evaluate and even compare different robotic systems. This is the current equipment in the United States. You can see several. There are three actually that now have hip platforms here in the US, and we'll discuss those. That's the Think Surgical to your far left, the Mako at the bottom, and the Zimmer Rosa on the right of your screen. I did want to take a second to discuss, there may be an opportunity here for a classification system of robotic platforms. And again, it's around these three elements. How is the pre taken care of? How is the intraoperative taken care of? And ultimately, how is the procedure executed? These would be examples of using this type of lettering system to classify robotics, and I think will be important as we look at literature going forward. The Stryker Mako, for example, does use a preoperative CT scan. It does evaluate for leg length and offset, and the execution is by direct placement with the robotic arm. This is in stark comparison to the Zimmer Rosa device, who does not need or require preoperative imaging. It's really acetabular only, and it provides a guide for the placement of the cup, not direct placement per se. So what does the literature say? Does robotics make us better at hitting our marks? Well, this is one of the very, very early validation studies on the Mako platform out of HSS actually. And this looked at a single surgeon, 12 cadavers, pre and post CT scans, right? So that is the truth. And it found that the system was actually good and reliable to within 3 degrees of cup placement and 1 millimeter of leg length. This is a similar type of study, but now done over 5 surgeons, still cadaver hips, pre and post CT scans, showing the exact same findings within about 3 degrees for cup position and 1 millimeter of offset. But does it hold true in living people? Seth Jarabic, again out of HSS, looked at 20 patients. Now, these are living patients. These are actual hip replacement patients, but again, evaluated with pre and post CT scans, and again, found the exact same thing. Very reliable placement of the components. This next study is perhaps one of the best ways to look at it. This is 120 robotic-assisted total hips over 4 institutions, which shows, again, Mako robotic platform is far more accurate than manual positioning for the cup. Dr. Dom and his colleagues actually looked at how does it relate to what technology used and the surgical approach that's used. This is a look at nearly 2,000 total hips. And these total hips were done in various different ways, different approaches, anterior, posterior. Some were done with using a conventional type approach, some using a posterior approach with X-ray. Fluoroscopy was used. You know, a lot of people here in the US are adopting fluoroscopy along with the anterior approach. And then, of course, robotics with a posterior approach and an anterior approach. And what this study found was with robotics, the placement was precise, independent of the approach. Now, before I go through, I want to look at this data in more detail, but before I go any further, I want to show you what I mean by using fluoroscopy intraoperative, because here in the US, there's a lot of interest around that. So this is a standing preoperative X-ray of this patient, and you can see intraoperatively the fluoroscopic images on the right. Now, you'll notice the pelvis is in a very different position on the top X-ray versus the bottom. And that's because the change in the C-arm position makes a dramatic change to the pelvic position and ultimately where the cup should be and is targeted. This is just the post-operative film in the recovery room, which is supine, and honestly of very little help other than to say there's no fracture post-operatively. This is another look, another example of intraoperative fluoroscopy, and specifically how it cannot be fully trusted. This is the intraoperative film, and you may say, hey, that looks pretty good. But these two films, you'll notice, the one on your left is the post-operative film, again, the patient being supine. But when this patient stands, you can see the dramatic position of the pelvis and how that changes the cup. The cup here has not moved from one picture to the next. This patient has been followed for quite some time with a stable cup position, but that cup position is very different depending on where the pelvis is. So C-arm is challenging to be used intraoperatively. This is back to that study of nearly 2,000 hip replacements that showed with robotics, whether anterior or posterior, the positioning of the components were actually quite good. This is a meta-analysis that looked at the robotic total hip literature. This largely looks at the Mako platform as well as Think Surgical. Again, it shows accuracy. We're able to hit the safe zones, we're able to get consistent offset, and we're able to minimize that leg length discrepancy with this advanced tech. But does it have an effect on patient-reported outcomes? Well, the early data is showing yes. In this study specifically, robotics versus manual, the robotic patients had a higher forgotten joint score with, again, no dislocations and no leg length discrepancies. Certainly a dislocation is an event that the patient cares about deeply. It's hard not to talk about this study when you talk about Mako total hip. This is Dr. Ilgen, a single surgeon study that looked at his first 100 total hip replacements in practice, then his last 100 in practice before his conversion to his first 100 in the robotic space. And the results are actually quite impressive. Again, we see that they had higher modified Harris hip scores robotically than manual, and even higher UCLA activity scores. An impressive finding. These are those findings represented graphically. But let's look back at that issue of dislocation. You'll notice in his first manual 100 in practice, he had 5% dislocations. You can see where they were and, in fact, kind of the broad spread of his cup position. You can see he improved with cup position, again with the manual technique. The middle column is his last 100, just before he converted to the robotic platform. You can see his cup position is improved, but he still had a 3% dislocation rate. And then ultimately you can see the far right column is his first 100 cases with the robotic platform, and there are no dislocations. Now, what you'll notice is those dots, though, occasionally are outside of that so-called safe zone. It's because the surgeon was able to hit his specific target for that patient. Well, let's talk about that just a little bit. And I know we've had some other talks about this already. What is the safe zone? This is the Mayo study showing that 60% of all hips that dislocate are actually inside the safe zone. It was really Larry Dorr, this is his paper from 2007, that showed that 75% of impingement is actually bony, not the implant itself. This is a study looking at lumbar fusion patients where the dislocation rate approached 8%. So why do hips dislocate? Well, surgical approach is perhaps a factor, but also femoral position, impingement, both bony and soft tissue, pelvic tilt, and spine. So what we really need is a system, a robotic system that allows us to accurately assess all of these factors. So look at this case with me. So this is the standing AP pelvis, but then the standing and sitting lateral spine films that show that this spine is actually quite stiff. We're able to make adjustments for that within the robotic platform. Instead of just planning like this, two-dimensionally and digitally, we're able to plan in 3 dimensions. These are the Stryker Mako windows that show that the green is the bone being taken away, and in that smaller picture to the top left, the green is the outline of the acetabular shell. The blue on the bottom picture is of course the femoral implant. So we're able to select these sizes very carefully and how they fit in the bone. But also, now that we know the dynamic position of the pelvis, we're able to take the hip through a simulated range of motion to see where it might impinge. You can see inflection of 90 degrees and internal rotation to 60 degrees or so. This patient does impinge. You can see an extension, 10 degrees of extension, 16 degrees of external rotation. You get no impingement, but with further external rotation here to 27 degrees, there's impingement. So preoperatively, we can know the dynamic position of the pelvis to know exactly where they will impinge. Well, what does this really look like? We talked about the planning some. This is the layout in the room. The back table similar. There's the robotic arm. This is a posterior approach. The patient's in the lateral position. First, you register the acetabular bone to the preoperative CT scan. You can see here in that left image the array that's placed in the pelvic brim there, and it does face towards the eye. Once you have registered those points on the acetabulum and verified its position, you can then use the robotic arm to ream appropriately the acetabulum. We want to take away the green in this picture. Ultimately, we'll use that same robotic arm to place the cup in the exact desired position. Then we can reduce the hip, assess the leg length and offset, and here you see that we're 2 shorter than pre-op and 1 decreased, but equal in length to the opposite side and 1 increased in offset. So you get the information versus pre-op and versus the opposite hip. So what are the key takeaways here? Well, hip replacement is a successful procedure. Complications do indeed exist. Robotics offers a possible solution. In short, better is possible. I look forward to discussing this and maybe some cases later in the day. Thank you for having me.
Thank you very much. Excellent talks. I enjoyed them very much. Okay, let's start our panel discussion. Are there any questions from the panel or the audience?
I'm happy to ask a question. For the first talk, there was a very good talk about the iliopsoas impingement. Do you find any difference when using larger head? We're trying to look at our data with dual mobility, especially the anatomical dual mobility that gives these larger heads. Do you have a higher rate of irritation of the iliopsoas with those larger anatomic heads?
Thank you for your very excellent question. Actually, we didn't check the large diameter head in our country. We only used the 36 is the largest diameter, but we didn't have any data comparing to 36 versus dual mobility articulation. But within the conventional head, 28, 32, 36 in our data, there have no difference. But you know that Ceramic company, they cut the inferior edge of half, the 1/4 of the inferior part to prevent sustained impingement when they're using the larger diameter head. Yeah. Thank you for excellent question.
Do you see a difference in different approaches, posterior approach versus anterior approach?
That's a very, 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 very good question for us. Yeah. You know, actually, Corey know that my boss is Professor Yun-Soo Park. He did 10,000 primary total arthroplasty only using the anterolateral approach. So I'm the successor of him. So I use only anterolateral approach. So we didn't compare the approach, but one very interesting paper from Japan, they compared the posterolateral versus anterolateral. Anterolateral approach had higher prevalence instance of iliopsoas impingement. So in our thought or observation, we cut some anterior capsule during the primary total arthroplasty when you're doing anterolateral approach. Then the iliac tendon exposure to the joint inside. Yeah, so the excursion, the iliac tendon more straightening by the removal of some of the anterior capsule. So personally, I asked some my colleagues in Korea. So anterolateral approach, higher incidence of impingement. The second observation, when you're doing the posterolateral approach, the cup placed a little bit posterior comparing to anterolateral approach, So the two reasons, the slightly more anterior placement of cup and the straightening of iliac tendon. So there's a higher incidence of, our series. So nowadays, we check always the tension of the iliac tendon intraoperatively, and that's too much, then we release the iliac tendon preventively to prevent iliac impingement. That's a very, very good question. Thank you, Professor Schwarzkopf.
Dr. Lin?
Dr. Sung, if I could follow up on that question, because I'm also very interested in this pathology as you are. And the concern that people have is that the incidence of weakness in hip flexion with the iliopsoas release is actually higher than the incidence of impingement by almost a factor of 3 or 4. So have you noticed by doing an isolated arthroscopic release much residual weakness in the patients that you have treated, and how long does it last if it resolves?
That's also a very, very good question. The quality of question is very, very excellent. So very difficult to answer, but so the next answer also related to our boss, Professor Yunsu Park. He did 10,000 primary total anterolateral approach, and about the first half of the hip arthroplasty, he cut the iliopsoas tendon routinely. But after experiencing the weakness, the early post-op period, he changes to do not cut the iliopsoas tendon. So previous problem is weakening of the flexion power. It lasts about 2 or 3 months. So he changed to do not cut the iliopsoas tendon, but the next problem is about 3% of iliopsoas impingement. So that's very dilemma for me when I'm using the anterolateral approach. So nowadays I cut the iliopsoas tendon selectively for the tight patient, but personally I check the flexion power during the post-op follow-up. About half of the patient complain some weakness of flexion power, but it regained after 3 months. Yeah, so after 3 or 6 months, the power gets to be similar. So anyway, early post-op period, flexion power is a little bit lower comparing to non-arthrotomy patient, non-psoas tenotomy patient. Thank you for an excellent question.
Dr. Lin, there's a question from our audience. And the surgeon asked, under what kind of circumstances would you consider the IPT problem, and how do you confirm your diagnosis? Do you use any needlework to inject some medicine to relieve pain, then you can confirm your diagnosis, or you only depends on your clinical finding and image findings?
Thank you. Thank you for, this is also very nice question. So the approaching to iliopsoas tendinopathy, number one is history taking. Typically, patient complain of pain when they changing cross. One leg standing makes, the contraction of the iliopsoas tendon. So the pain in changing cross, or getting in out of the car is the first step of suspicion of the iliopsoas impingement. And number two is the physical examination. The resisted SRL is typically cause severe pain in the groin area. Then third step is imaging. So in our hospital, fortunately, we have a very nice metal artifact reduction sequence MRI. So we can check the MRI. Some 80 to 90% of the patient confirmed iliopsoas impingement had some synovitis in the axial imaging of iliopsoas tendon. The number four step is, conservative management, the stretching exercise, medication, and some patient we give injection, but injection, we do anterolateral approach, but the injection can cause the spill some material into the joint. So I very cautiously do the injection for the patient. So then if the conservative treatment failed to relieve pain, we ask them, you can be better by simple arthroscopic iliopsoas tenotomy. Do you want to surgery? So I just ask them, and patient decision is, about half and half. And so fortunately, in my hand, now I am having 20 or 30 cases of iliopsoas tenotomy using arthroscope. Most of them have improvement symptom, and 80% is completely. So patient satisfaction is very high after the arthroscopic surgery.
Thank you. Our next question is for Professor Schwarzkopf. So according to your classification, you classify your patients into high risk, middle risk, and low risk. So if they are high risk patients, do you routinely calculate a specific target for cup positioning? And how do you achieve quite accurate positioning of your acetabular component? Do you routinely use a robot or navigation system?
So I calculate for all of my patients, because all of my patients get the standing and sitting full body imaging.
Mathematically, or just a trend? So let's say because the pelvis rotates more anteriorly and posteriorly, then you see the trends. Then according to the trends, you see, so you fine tuning your cup positioning, or do you have an algorithm to mathematically calculate?
So I calculate that I want the cup in a 40 to 20 degree in their functional pelvic position when they're standing. And then I calculate how much is that to the anatomy. There's an algorithm, a formula that's published with Dr. Vigdorchik and myself. So I do the calculation, because when we operate to the anatomy, not to the functional. And then I use navigation in 100% of my cases. And a lot of my colleagues, like Dr. Vigdorchik, uses robotics in all of his cases. Because if you don't use navigation or robotics, you cannot hit an exact target. So I calculate an exact position that I want, and I use navigation to achieve that in my cup positioning.
Okay. Can you teach us or tell us what's the role of the stem positioning? Do you routinely do the stem side first, or you routinely do the cup side first?
I routinely do the cup side first. And then in these high-risk patients, I always try to use a high offset stem, and I try to maximize the head size, either by using a large head or considering dual mobility, depending on the case. And I will consider putting a little bit more anteversion in depending on the case and the risk in the stem. But a lot of times the position of the stem with a regular primary stem is limited by the anatomy of the patient. If in extreme cases or more complex cases, you can use a stem that allows freedom of anteversion, if it's more of a Wagner type stem or it's a modular sleeve stem.
Thank you very much.
I have questions.
Yes, please.
Yeah, I have questions for short. As we all know, the hip and the spine relationship is hot topic recently. As we all know, that spine contribute to 20 to 30 degree movement when the people move from standing to sitting. So if the spine is fused, so the 20 to 30 degree movement last. So maybe this is increase the burden of hip joint. So whether simply adjusting the cup position is enough to prevent the impingement, both extension and flexion. So this is my questions.
So you are correct. You described exactly the problem that happens. So a lot of it depends where is that pelvic and spine fused, in which position. The extremes are what we like to nickname or call it fused in standing or fused in sitting. Yeah. The reason that we see more of these dislocations now, and it became a hot topic, I think relates to how our spine colleagues have improved their technique, and instead of fusing in situ, which they used to fuse in the past, now they correct to what they call a more functional lumbar lordosis, and they fuse the patient in a more standing position. It should be less extreme in older patients, but some spine surgeons put them in a lot of lordosis. And those patients, when they sit, they can impinge in the front and come out the back. So you have to move the cup and add more anteversion to clear that area in the front and protect in the back from the cup, the head coming out. It's to say that it's enough, it's probably not the correct saying. It's better. So we're trying to make a more safer zone. But as I showed, every patient has a cone, an area of freedom of movement before he impinges and comes out. In these complex patients, that area becomes smaller. They have a smaller safe zone, and it's harder to keep them stable. So by moving the cup, we try and put that smaller safe zone into their functional area. So for those patients, when they sit and stand, they will be within the safe zone for them. But in some patients with very complex position of their pelvis, that safe zone is very small. And even if we put everything in the perfect position, they could still be at risk.
Yes.
Our next question is to Kari, Dr. Calendine. There's a problem actually confused many Chinese surgeons. The Mako total hip system actually referenced to the plane when the patient's lying on the CT scanner to the CT the plane when the CT scan is taken, rather than reference to APP. And we have a lot of patients with quite significant deformity, hip deformity, spine deformity. So what's your opinion about that? So do you think we have to reference to APP in order to eliminate the difference between patients to patients?
Yes. Yes, I do. Thank you so much for the question. Really a smart, well thought through question. You're talking really about the difference between the supine when they're laying in the CT scanner, the supine pelvic position versus the standing position that Rand was helping us with about the functional pelvic plane when they stand. Yeah. It really is their functional position that we care about the most. What I showed you there towards the end of the slides was actually what in the US has been launched as Mako 4.0, and it addresses just that issue. It addresses the fact that when they're laying in their scanner versus standing, now 85 or so percent of people have about a 6 degree difference between supine and standing. But in that one case that I showed, it can be quite dramatic. So the supine pelvic plane should not be trusted for the functional pelvic plane. So in the Mako 4.0, the updated software, you actually take a lateral standing and sitting of the spine and put those numbers, the sacral slope numbers, into the computer system so that you can get some of that impingement information that Rand keeps referencing. I really think there's a strong understanding of the problem, but I would just restate one point here is we do need to be paying attention to the femoral side, and probably all of this discussion is for naught unless we have a tool, be it navigation in Dr. Schwarzkopf's hands or robotics, to really hit these pretty narrow cones.
Thank you very much. See, 4.0 is appealing. Unfortunately, it's not available in my country. So I guess the first step is to define how large is the cone Rand has just mentioned. Is that right? You have to define the target range of motion. Otherwise, you can't simulate with impingement or not.
Yeah, I think in a lot of the technologies, as Corey said, not just in the Mako, but a lot of them in the future, you will put the patient information in there, you will put the spine information, and they'll give you that cone of safety. And you'll see some patients have a larger cone, some patients will have a smaller cone. And what we can do as surgeons is try to put the implants in the best position for that specific patient. And sometimes that cone changes with life. We'll have a young patient, and as they grow older, their spine changes and things can change.
Great. Thank you very much.
Guys, but Corey and Rand, just to make it a little bit simpler for folks who do not and won't for any time soon have access to a robot, there's other things we can do as surgeons to sort of think through these opportunities and avoid the mistakes of the past, right? Because a lot of the work you've done is shine a light on a problem. But we have other ways to deal with it. We know that basically if it's a fused spine, it's fused stand, you may want to antivert the cup a little bit. You might want to change to an anterior approach, right? You might want to get a larger head. If you were on the fence of 32, 36, you might go for a 36. And then you might even think about more aggressive post-operative precautions for people. So I think there's things we can do as surgeons without a robot that still help. And Corey, I'm curious what your experience was, but when I got my Mako, one of the things that surprised me the most was how little antiversion there was on a whole lot of femurs. I always assumed they're 20 or 30 degrees antiverted, but a whole bunch of them 10, some of them were 20 degrees retroverted. And I wasn't really thinking femur, but I think that's something else you guys have taught us is there's the femur and the socket. And if you can't get too far in the socket, you just remember you can always work on the femoral side to buy yourself some stability. Did you agree with that?
Yeah, no, I completely agree. And the one thing in your list, Stefano, which was brilliant, is offset, right? We can increase offset too, because Larry Dorr taught us so much of this is bony impingement. But you're right, there are some principles here that even manual surgeons can use, and I use in revisions, right? And I think this really pushes the conversation forward. But you're right, we need to step back and make sure that it's applicable. Thank you for that.
Thank you very much, friends. Due to the limitedness of the time, I have to close our panel discussion and invite my friend, Professor He Chuan, to deliver his speech.
Hello, everyone. I'm Dr. He Chuan from Region Hospital, Shanghai Jiao Tong University Medical School. It's my pleasure to join this seminar focused on leg discrepancy and stability. I will share a case with chronic dislocation after a revision total hip arthroplasty. Instability remains a serious complication following total hip arthroplasty. Dislocation rate after primary total hip arthroplasty vary from 0.3 to 10% and even higher after revision THA, with a prevalence of up to 28% according to the previous reports. Instability of THA is the most common reason for revision surgery, about 22.5% in United States, And it's the second most common reason for revision according to the Australia and the UK registry. Several risk factors for hip instability have been recognized, including previous operations, soft tissue damage, advanced age, neuromuscular diseases, cognitive impairments, and pelvis instability. The picture shows femoral neck fracture patients with mental disease. She can't cooperate to any position advice. So obviously, this patient is with a very high risk of dislocation after THA. So I perform a minimal invasive approach THA for her with dual ability prosthesis. In surgery, I get a very stable joint. After surgery, the patient kicks the abduction pillow away and twists his body uncontrollably, but I didn't worry about the dislocation because his hip is very stable. So understanding the etiology of the instability is essential for appropriate management to prevent the dislocation after surgery. Let's come back to the case we will discuss. In June 2002, 3-year-old woman with right hip neck fracture underwent cementless THA. 10 years after index THA, she sustained a great trochanter fracture and posterior THA dislocation after she fell down. The reduction was successful under general anesthesia, but 3 further dislocations occurred in July 2013, February 2014, and February 2019, respectively, and were all treated by close reduction. In February 2019, the patient suffered from a dislocation again after he fell down. The revision surgery was performed in other hospital with Zimmer TM cup, Wagner SL sting, and the trochanteric claw plate. Both of the primary and the revision surgery was performed through an anterior lateral approach. The surgeon performed the revision surgery recorded that they found sting loosening, atrophy and fibrosis of the gluteus medius and great trochanter defects. Unfortunately, 2 weeks after revision, the patient sustained a post-operative dislocation and treated by close reduction and skin traction. But the dislocations occurred several times in 2 months after revision surgery. The dislocation always occurred at the time of the raising buttocks. We did reducing artifacts MRI and 3-phase bone scan examination for this patient. The exams revealed no signs of the acetabular and femoral components loosening, and the positions of the implants were evaluated on the CT and MRI images for the hip joint. The cup showed an inclination angle of 51 degrees and an extensive anteversion of 45 degrees. A sting and the torsion angle was 26 degrees. So chronic anterior dislocation after revision THA was diagnosed. A revision was inevitable since the hip had dislocated for 4 months. The question was how to revise this hip. Total or partial revision? Could a cup revision or stent revision alone? Even a linear exchange work? Should the muscle transfer be prepared to repair epiductor deficiency. After revision, I found the atrophy and the fibrosis of the hip epiductor, but no deficiency identified. Acetabular cup and femoral sting was well fixed to the bone. The patient's acetabulum appeared to be over and inverted and slightly upright, just as the picture shows. I tried to adjust the elevated rim of the polyliner to the superior anterior corner, but hip still dislocated at extension and internal rotation of the hip joint. So decision was made to maintain the well-fixed sting and increase the stability by revise the cup to the less degree of anteversion and inclination. I put a new cup with 10-degree anteversion and got a combined anteversion of 35 degree. And excellent intraoperative stability was demonstrated as the video shows. After the reoperation, hip epiduction pillow was used for 4 weeks. Early post-operative ambulation was started at 2 days after surgery. Walking with a walker was possible 2 weeks after revision. After her most recent follow-up at 26 months, radiographies showed persistence are very stable with no recurrent instability. With a little bit limp, the lady come back to her activities of daily living. So patients was very satisfied for that. Post-THA dislocation is a challenging multifactorial complication with multiple treatment options. According to the literature, 6 cartridge of the post-THA instability are identified. Type 1, malposition of the acetabulum component. Type 2, malposition of the femoral component. 3, epiductor deficiency. 4, impingement between prostheses. 5, latent wear of the polyliner. 6, unclear etiology. The key to treatment of this problem is understand the cause of the instability. As we know, epiductor deficiency repair is challenging work. This patient has a history of great trochanter fracture unhealing. Fortunately, in this revision, I found the great trochanter fragment rigidly fixed by a claw plate in last surgery. And the most difficult part in this revision surgery is reduce the hip due to the hip dislocated for 4 months. So after I reduced this hip, it's very stable. So the muscle transfer didn't perform. In this case, major cause of joint instability may be an anterior approach and malposition of the acetabulum component. This case tells us anterior approach at the extensive anteverted acetabular cup maybe have a very high risk for instability after THA. Thank you your attention.
Our next speaker is James Slover. Is James online?
I am. I'm going to share my screen here.
Good.
I'm very excited to be participating in this program, and like some of the earlier speakers, I look forward to the times where it'll be easier for us to do this in person. I'm going to talk about a case report using dual mobility, liner, and head in revision total hip arthroplasty. This is a case. Also, I just wanted to thank Dr. Schwarzkopf, who helped with some of the pictures, and our disclosures can be found at the AOS website. This is a case of a 60-year-old female who had 6 months of left hip pain in the groin with some radiation, and she had failed conservative management, including anti-inflammatory medications, use of assistive devices, and activity modifications. As part of her preoperative workup, she had a hip aspiration that was negative for infection, and she presented with increasing pain and eventually inability to bear weight. Her past medical history is shown there, and she'd had a left total hip in 2008, as well as hypertension and osteoarthritis. Her BMI was 23. She did have, on exam, tenderness to palpation at both her groin and pubic tubercles. She had a significant leg length discrepancy, but she was neurovascularly intact. Range of motion and gait was difficult to assess because of her inability to bear weight. And her laboratory values are shown there. A white blood count of 8.7, a sedimentation rate of 43, with elevated metal ions of both cobalt and chromium as shown there. These were the x-rays that we had from the past with her, and they show bilateral hip replacements. And on the left side, she has a metal-on-metal hip replacement. At the time she presented this way with obviously displacement of the cup, as well as a significant fracture of the acetabulum and pelvis. Here are the Jade views showing the disruption of the columns, reflecting a discontinuity. Here's a lateral view, again showing displacement of the cup, as well as the position of her femoral stem. Here you see some selective MRI cuts showing an inflammatory reaction around the prosthesis, with a fluid collection as well. So at this point, her workup is consistent with a fracture, likely secondary to metallosis from her metal-on-metal implant. And she has obvious failure of her acetabular component. Fortunately, her workup has not been consistent with infection to this point. So we took her to the operating room using a posterior approach, which is the most extensile approach in my hands, and what I use for most of my revision work, especially if there's going to be extensive acetabular work. You can see here the caseating material that was found and the necrotic material that was found in the joint, indicative of the metallosis that she had, causing the adverse tissue reaction, which was the inflammatory reaction that incited this process, most likely. And also shown here is the large housing for the trunnion on the very large femoral head that was used on the component. Here you see the trunnion, which does show evidence of trunnianosis, creating the metal debris reflected in both the preoperative labs as well as the soft tissue reaction shown on the MRI studies, as well as here intraoperatively. It is typical for me to always get an MRI in a metal-on-metal implant if there's pain, to assess the potential for an adverse local tissue reaction, as sometimes the damage can be quite severe before it becomes significantly symptomatic for the patient. In this case, of course, with the fracture, it was significantly symptomatic at the time of presentation related to both that as well as the soft tissue reaction. One of the important considerations here is whether to retain the femoral stem or not. It becomes a judgment call related to how much damage you may see on the trunnion, whether the stem is loose or malpositioned. And sometimes there's a sleeve available that you may be able to place over the trunnion to minimize the effect of any damage before placing a head in a revision scenario. The patient's age and the morbidity are all factors that can be carefully considered when deciding whether to retain or revise the stem in a situation like this. But what I wanted to focus on for this case presentation was how we managed the acetabulum. There's obviously many potential complications in a case like this, but with this type of significant soft tissue damage, including significant damage to the abductors, and with the type of reconstruction, instability and dislocation is one of the significant risks that we want to try to do everything we can to minimize with our approach and reconstruction. Here we can see, once the implant's removed, a significant defect. The first step was, the decision was to use a cup cage type construct. And so the first step was to place a cup into the defect using a highly porous coated surface with as many screws as we could get for initial stability. Then placed a cage inside of the cup as shown here. And what is shown here is the use of potential dual mobility. Inside the cage, we then placed a dual mobility liner or cup, depending on how much size you have, which we will eventually cement in so that we could use a dual mobility construct to help with our stability after we reconstruct the acetabulum using a cup cage reconstruction. That final reconstruction is shown here. So again, it's an inner cup supported by a cage. We then cemented a dual mobility cup or liner into the cage so that we could use the dual mobility head to help increase our stability, avoid dislocation with this complicated reconstruction. Despite the abductor insufficiency and the extensive loss of tissue related to the adverse local tissue reaction to the metal particles and the fracture, as well as the dissection that's needed to do the reconstruction itself, which often requires the removal of significant scar tissue, which can impact stability significantly. So here's the final reconstruction using the dual mobility head inside of that liner, which is cemented into the cage, which is supported behind it by a cup. And here's the final X-ray showing that construct. So again, there's the inner cup. It's then supported by a cage. You can then see the cemented dual mobility cup inside of the cage, and you can adjust the version to some degree as long as you have adequate cement to support that cup. And then a dual mobility head is used to achieve stability in this complex reconstruction for this patient, despite, again, significant soft tissue compromise of her abductors, inflammation related to the metallosis, and the extensive scar tissue that's removed as part of the reconstruction. And this is a technique that I've used many times, not always with a cup cage, but many times I have cemented a dual mobility liner or cup into a larger cup when needed, and that has helped me obtain adequate stability with the implants in many revision situations. And it's something to keep in mind since instability is one of the major challenges with any hip revision, particularly in acetabular revision. Thank you.
Thank you very much, James. Great case. Are there any questions about these two cases? Questions or comments about these two questions? Dr. Slover, may I ask whether you retained the stem? So it seems you retained the stem, right?
In this case, yes, the decision was to maintain the stem. I think that's a judgment call, depending on how much damage may be there, what the morbidity to the patient may be, and so forth. If the trunnion is overly damaged, then sometimes you do need to revise the stem. And it's a little bit of a risk-benefit analysis based on the individual patient and what the morbidity of removing the stem may be for them.
Yeah, I do believe you have good reasons. But are you concerned with the long skirted femoral head? So probably, at least theoretically, for very active patients, this may lead to further corrosion. Is this an issue to you?
It is an issue. It's certainly been shown, I think, pretty clearly that the skirted heads, as well as the larger heads with the plus sizes, so 40 heads that are, especially if they're a plus, more than a +0, have greater issues with trunionosis. I think the other issue that you have to carefully consider is impingement of that skirt. Even with a dual mobility, that can still occur, and you can get dislocations or intraprosthetic dislocations. So I think you have to balance all of that against what you're trying to achieve with stability in terms of the patient's range of motion and leg length restoration, et cetera. And to the conversation earlier, this is where I think that, very systematic and aggressive assessment of stability in the operating room is still the most important step before you leave. You have to feel certain that it feels stable through a functional range of motion. Otherwise, it's not likely to work for the patient.
Yeah.
One of the, if I could add something to that, the question of the stem size, one of the things that also you have to keep in mind is a track record for that particular stem. So if you're familiar with the stem and you understand that this is a stem that has excellent distal fixation, you're good. If it's a stem that has entirely metaphyseal fit and fill, that's probably not a good choice. So there's also this important thing to keep in mind that as those of us with less gray hair have had to see some of these implants come and go. There's an interesting test I've never written up, but I'll share with you guys, which has to do with testing anterior instability. Most people extend the leg and externally rotate, which is not a physiologic event. It doesn't happen. What generally tends to dislocate hip anteriorly is a psoas tendon. And so if you flex the hip and externally rotate, and then you put your fingers inside around the neck and lift it over the front of the hip, that is where you can really tell if your hip is unstable. I call it the anterior translation test. It doesn't happen just by extending the leg. You have to flex it, and see if you can bring it over the front. And I saw James nodding because it's one of those things that just external rotation, that's not adequate to test for anterior instability.
I would agree completely. And I think that even in a routine primary hip, if you use a posterior approach and a lip liner, I think you have to be very careful where that lip is. It has to be rotated such that it doesn't impinge in that point that you're describing right there, which is, flexion and external rotation. If the lip is placed a little bit too high, you can get impingement there even from a posterior approach and dislocate anteriorly. And I think it's something to be very careful of.
Yeah, I think this is very valuable. Just like a total knee, you have to flex the knee a little bit, then to test the coronal instability.
I have a question to Dr. Slover.
Yes.
In some cases, I also use the cup technique, but the concern is the cement interface between the two cups. So when I doing the cup technique, I use the screw hole, align the two cups, then I put one screw through the two cups. Yeah, you know what I mean? And then little bit early phase of cement, then I simulation the pass of the screw hole, then cementing, then before the the cementing the early phase of the early dough phase, I put the screw through the two cups. So what do you think about my idea?
Well, I think it's a great idea. It sounds very technically challenging to me. So I applaud you for being able to do that. I think anything you can do to improve your fixation. I do think I've had, a lot of these revisions, even this case, usually the cage and the cup that's put in first is quite large. And I find that if I can get a good cement mantle around a smaller, dual mobility cup that fits inside of that cup, that the fixation is actually very strong. And in fact, I had one case where I did this and then I decided I needed to reorient, and it was very difficult to get the outer cup out without stressing the inner construct and the screws and causing more fracture because it was such a strong bond. So I think it's great if you can do that. It sounds very technically challenging to me, though.
Thank you.
How much? Just to add to what Dr. Slover said, the case that he showed that he did, the outer cup is fully porous cup. There is no locking mechanism. It's designed to have a cement liner option into it. So cementing into a fully porous cup is the easiest cementation. It's the best material to put cement on. And the cup that is cemented inside is a cup that's meant for cementation. It's a monoblock dual mobility cup that's meant to be cemented into that acetabulum. So you're using two cups that cementing between them makes a very, very strong bond because they're meant for that.
Yeah.
How much clearance?
But I've used others where they're not, and it still works as long as the cement, you know, the outer cup has enough cement around up to its rim, so that's really has cement to the rim. I think that's really the key.
And the clearance that you asked, I usually do a 13 millimeter difference between the outer cup and the inner cup outer diameters, but that depends on the thickness of the cup. So you can always take the trials and see which one fits.
Okay, thank you. Yeah, I have questions for Professor He Chuan. Yeah, do you, yeah, just because this patient, the primary total hip approach is anterior approach, right?
Yeah.
Yeah. Do you use same approach to revision or posterior approach?
No, the primary THA and the first revision THA also did in other hospital. It's also use the same approach, anterior lateral approach. So I do the second revision. Also use the same approach. I don't want to did not cut on the hip.
Okay, okay. How to repair the soft tissue because after dislocation the soft tissue has already injured. How to fix and repair the soft tissue?
I prepare the Maximus transfer for that, but in surgery, I found the soft tissue is okay. No is a significant deficiency. I can close that. So it's okay. So I don't perform any soft tissue repair.
Thank you very much for a nice discussion. We have to proceed to our next session, and my friend, Dr. Kevin Tan, will moderate this session. Dr. Tan?
Hi, good morning, everyone. I'm Kelvin. I come from Singapore. We had an exciting first half, and now we move on to the second half of this conference. We have a series of 3 wonderful talks, followed by a panel discussion, and then a case presentation. I'll be doing a short introduction of the 3 upcoming speakers as the self-recorded videos will play one after another. Our first speaker for the second session will be Professor Stefano. Professor Stefano is a professor of orthopedic surgery in University of California, San Francisco. He's very passionate about clinical, especially digital orthopedics. His talk will be on gluteal sleeve repairs. Our second speaker will be Professor Zhang Guoqiang. Professor Zhang, he is from the Chinese Liberation Army General Hospital in Beijing. He specialized in complex hip and knee revision surgeries. He will bring us a talk on reconstruction of the posterior capsule to increase the stability after total hip replacement. And our third speaker, who has just ended the first session, will be Professor James Slover. And he's been introduced before already. He's a professor of Department of Orthopedic Surgery at the NYU Grossman School of Medicine, Langone Medical Center, and New York Harbor Veteran Administration Hospital and Bellevue Hospital, New York. He'll be giving us a talk on the application of dual mobility in total hip replacement. Many thanks to the speakers for joining us on these precious Sundays, especially for the AAHKS surgeons as they are taking time off from the Thanksgiving holiday in US. Many thanks. Let's move on to the first speaker video.
Hello, and thank you so much for the opportunity to speak to you today about a topic I'm very excited about. At least on behalf of ASIA and AAHKS. So I am Stefano Bini. I am a professor of orthopedic surgery at the University of California, San Francisco, and I have a particular interest in gluteus medius tendon repairs, as well as minimus. I think it's a highly and often underdiagnosed problem that has a terrific and results in the right situation. So the indications for repair of the gluteal sling or the gluteal tendons or the abductor tendons, basically gluteus minimus and gluteus medius, are often for a missed degenerative tear. In other words, a patient that has a degenerative tear, one that wears out over time, very similar to, for example, a rotator cuff tear. There's also patients who've had an anterior lateral approach to the hip, and in those situations, perhaps the repair has failed and needs to be revisited. And also there's the metal ion related abductor deficiencies. You can also see them in aggressive polyethylene. What you see to the right is on this slide is, of course, a metal ion issue. This is what that particular patient looked like inside when we open up a hip. As you can imagine, after you have cleared all the dead material, you're left with a big deficiency, and sometimes these are very difficult to address. So this is how these patients present. This is a patient with a big abductor deficiency. I'm holding her hands and she can barely stand up, whereas on the other side, she has no problems at all. So it's a classic abductor lurch. They may walk with difficulty. They may have trouble with lateral hip pain as the only symptom. They may have been treated for trochanteric bursitis ineffectively for years. These patients are often at their wits' end, which means that they're very upset. They have trouble sleeping, they have trouble stair climbing. They often use a cane or have a significant side-to-side waddle. Frequently have had multiple injections. And again, if they've had an anterolateral approach to the hip, this can also be a suggestion for a gluteus medius tear. They may also have had a hip replacement and had lateral hip pain as well as groin pain, and had the hip replacement surgery. The groin pain went away, but the surgeon didn't fix the abductor at the time of surgery. And therefore, the patient continues to have hip pain on the side of the hip, even though their groin pain is gone. And the assumption is that they have a tight IT band or they need to do some exercises, but in reality, what they actually need is a repair of their adductor tendons. On X-ray, you'll sometimes see flattening of the lateral side of the cortex of the greater trochanter, but more often than not, the X-rays are normal. There can be occasionally small fractures of the tip of the trochanter as well. Ultrasound can be used if you do not have access to an MRI, which can be quite successful. An MRI is probably the best tool. And the reason for that is it shows you the extent of the detachment. It shows you fluid collections if you're dealing with a metal ion issue. It can show you the impact on both the medius and the minimus, but most importantly, and I'll tell you why in a minute this matters, you can see the extent of fatty muscle degeneration of the muscles that have been detached. We looked at a significant number of open repairs and compared these to closed arthroscopic repairs. The sports medicine surgeons were doing the smaller tears arthroscopically, and what we found is that both did quite well. However, the size of the tears that we manage open are much, much larger than the ones they would be managing closed. 70% of patients had good to excellent results, and 30% did not. That 30% were patients with very large tears, and frequently we found that those are the patients with fatty degeneration on MRI. So these larger tears are quite problematic. And but the surgery itself can be quite good at providing pain relief but if the muscle is degenerated and the tears are very large, frequently the limp is retained. So this is a drawing I made for you of the abductor tendon sleeve. You can see it's confluent, it's attached to and participates with the vastus lateralis. And what we're trying to do is reconstruct the connection, not just from the gluteus tendon to the trochanter, but also to the vastus lateralis as a way to create a compression hypothesis at the trochanter. This is what a tear, a degenerative tear might look like. These happen without specific trauma and are quite common. And this is what they look like if you were to open it up and take a look at the tear. Anterolateral approaches to the hip usually leave a defect that looks more like this, although I've seen these similar defects also from chronic degenerative tears. And occasionally you'll see something that looks like this at surgery, where you can see the, apologize my note here, but the video. And then sometimes you will see a full complete detachment of the muscles from the trochanter. And that's what this might look like. As you can see here, there's really nothing left attached to the trochanter at all. Circumferentially, both minimus and medius, there's really nothing left. And we'll take a look at how I repaired this particular tear in a minute. What we do is we identify the potential position for the anchors. So that each of these X's represents a suture anchor. The sutures are then passed through the tendon on all sides and then tied to each other to bring the tendon back. In order for this to happen, you have to release the tendon from its scarring. It usually is scarred to the minimus, usually scarred to the femoral neck, and also it is not retracting. So you need to be able to release it all the way up above the acetabular rim and away from the iliac wing in order to restore its elasticity. We take these sutures that are still attached and then re-tie them to each other so that we now have multiple attachments. If we have enough elasticity, I will do a 2-row repair like this. So this is what that might look like. Here is a large tear. As you can see, there's really nothing attached to the trochanter. We're clearing up the bony surface. We've now freed up the gluteal tendon sleeve from its scarred attachments and are adding the suture anchors. I use these metallic anchors because I like to see if they pull out and also where they go. And you can see now we've passed the sutures through the tendon and how elastic the attachment can be made. We reattach it down. And then if there's the sutures, once we've tied them down, I'll bring them back and try to connect to anything else we have elsewhere in the soft tissue area. And what you can see here is how effectively we're able to reconnect the gluteus medius to the trochanter. Sometimes I like to reinforce the repair with mesh. I use 2-sided Merceline polypropylene mesh, and then use the same sutures that are tied to the anchors to pass through the mesh to attach the mesh to the repair and also extend it distally so that I am connecting it to the vastus lateralis and any other soft tissues nearby that can be used as an anchor. So we do that, we tie the suture over, then I do a single running suture in the periphery, as well as all those additional sutures that we put through to anchor the mesh so that it's flush down to the trochanter and the muscle itself. I don't want it to be sitting above it. So this will be a 2-row repair. Okay, so this is what you see is a completely bare trochanter on this MRI. Well, this is the one we saw a little bit earlier. As you can see in a minute, we're going to be finding this anterior edge of the attachment. As you see, it doesn't want to go anywhere. It's scarred down. You can see how well it's scarred down to the underlying total joint replacement. We need to excise all this scar tissue. This is not gluteus medius. It's not contractile tissue. And we need to remove all of it until we've cleared it proximally into the iliac wing and above the superior surface. What we're seeing here is that I am now deciding where I'm going to put these anchors. We're going to put, I think, 4 of them in a row along the anterior rim of the acetabulum. We'll make sure that these are solid. When we pull on them, they don't pull out. These is fiber wire suture that's attached to this anchor. These are then passed through the leading edge of the gluteus medius, giving us enough room at the rim to have a second row of sutures if we need it. And here you are, you can see how I'm pulling this down to the trochanter. The hip in this situation is placed in neutral. I do not want it internally rotated, or I'm worried that the repair will fail. Once we tie these down, we compress the tendon against the bleeding surface of the trochanter and then create a second row of sutures. We added a couple more anchors here to make sure that we can connect these two together. So there you're now seeing that second row of anchors coming, bringing the trochanter down. So now you see how stable it is, how well attached it is to the troch. Again, using these sutures, once they've been tied, I'll take the free needle and run them wherever I can find a place to anchor them. We then take, again, the same sutures that we've used to tie the abductor tendon down to bone. These are sutures that are also attached to the anchors. Pass them through at the correct position through this mesh, and then tie down. That way it doesn't bunch up. You have to make sure that each of the screws come through, each of the sutures comes through where it was intended to. And here you're seeing us adding additional sutures to tack down that mesh so that it's flush against the bone, and excising any residual or additional mesh that is unnecessary or it's more than what we needed, so that it's custom sized. And now I'm going to take a suture and run it around the perimeter to really make sure that this mesh is flush against the repair, and it's going to now incorporate into the repair and support it. So this is what the X-rays look like post-op. And what you'll see is that actually at around 5 months, one of the anchors did pull out. And this is not unusual. I'll see that maybe 10, 20% of the time, but it doesn't imply that the repairs failed. In fact, many of these patients are asymptomatic and have returned to normal function. Post-operative care for 12 weeks is protected weight bearing with a walker. For 6 weeks, it's okay only if the tear is limited, less than 50%. And I really, really feel strongly about this 12 weeks for these very large tears. We do no physical therapy to speak of. The only thing the patient is allowed to do is walk with a walker. And afterwards, at 12 weeks, we encourage walking with a cane or walking stick and increasing progressively, slowly their gait, etc. The problem is that especially if there's fatty degeneration, the muscle will never fire again, and therefore the patient will retain a limp. What we do get, though, is a significant improvement in their pain and their quality of life as a result. But if the muscle is degenerative, I'm afraid that we cannot fix that problem. Okay, next, we've had to reoperate on a couple of few patients for different causes of dislocation. What you see here is how well embedded that mesh has become into the repair. The repair is still very, very solid. And that was terrific. This is another patient we looked at who also had incorporated the repair super well. You can see how well the attachment of the gluteus medius retains. And then you'll see here another one that actually also had a very interesting and very solid repair, except you can probably see that the trochanter is moving below this mesh. And so what I did with him is I actually went back in and just added some tack down sutures to connect that repair. And then you'll see that it's actually more stable now. He was asymptomatic. He actually dislocated, so that's why we're back in there. But it was interesting to see. So in summary, consider the presence of a gluteal tendon tear in your differential diagnosis of a lateral hip pain, especially after a primary hip replacement. Use an ultrasound or MRI for diagnosis. If you find that incidentally at surgery, please consider fixing it with a couple of suture anchors, because these patients will otherwise continue to have lateral sided pain even though you fix their groin issues. And we can't fix everything. If the MRI shows extensive fatty degeneration in the muscle, it probably will never work again. The patient will have trouble walking, but they will hopefully be pain-free or very close to it. With that, I want to thank you. It's been a pleasure to be here, and I appreciate being invited.
Good morning, everyone. I'm Guoqiang Zhang from 301 Hospital in Beijing, China. It's my great honor to be here to present my speech. My topic is reconstruction of posterior capsule for reinforcing the stability in total hip arthroplasty. As we all know, many factors cause instability after total hip arthroplasty. These factors are mainly divided into three aspects. Patient factors include age, gender, ASA score, surgical history, muscle strength, primary diseases, and so on. Prosthetic factors include offset, liner design, head diameter, head-neck ratio. Iatrogenic factors include malposition, experience, impingement approach, and soft tissue reconstruction. Here, we just focus on the approach and the soft tissue reconstruction. From the table, we can find both anterior lateral approach and the direct lateral approach have low dislocation rate. The posterior approach with repairing the soft tissue significantly reduce the dislocation rate compared to the unrepaired soft tissue structure. There are two soft tissue structures at the posterior of the hip to stabilize the joint: external rotators and the capsule. Which of these two structures has a great effect on the stability of the joint? This article did a cadaver study on the issue, apply a traction force of 250 newtons to the acetabular and femoral head in opposite directions. Measure the separation distance of the head and the socket. The result showed that in the posterior approach, the separation distance increased significantly after the capsule was resected. Where the increasing of separation distance was not obvious after the external rotators were resected. Similar result was obtained with the anterior approach. This showed that the posterior capsule plays a great role in the stability of the posterior of the hip. This has a great correlation with the anatomy of the capsule. So let us review the anatomy of the capsule. Actually, the capsule is a capsular ligament complex, including iliofemoral ligament, babofemoral ligament, ischiofemoral ligament, zona orbicularis, and spiral fibers. Ischiofemoral ligament can restrain internal rotation during neutral position and during combined flexion with adduction. Zona orbicularis acts as a locking ring around the femoral neck to avoid hip dislocation. So when the hip moves from extension to flexion, these structures gradually tighten, just like a hoop, to maintain the stability of the hip joint. However, in general, after implantation and the reduction, the capsule does not have enough length to be fixed to the great trochanter. And this video shows in the neutral position of the lower extremities, there is a clear gap between the capsule and the great trochanter. This picture just shows the same situation. Only when the hip is abducted and externally rotated, the capsule can be fixed to the great trochanter, but when the hip returns to the neutral position, the risk of avulsion of the capsule will be increasing. And this is an article published in 2019. It evaluates the influence of the posterior capsule on the range of motion through in vitro biomechanical testing. From the picture, we can find that the hip resurfacing total hip arthroplasty and duromobility total hip with repaired capsule are stable through a full range of motion. However, when the duromobility total hip without repaired capsule was applied, the dislocation risk increased during deep flexion. As for the conventional total hip arthroplasty, whether the capsule was repaired or not, the dislocation risk all increased during deep flexion. These articles describe the result of the soft tissue repair post-operation using metal markers. The results show that there is a 75% to 80% failure rate of soft tissue repair. Based on these issues, we designed two new techniques for reconstructing the posterior capsule. One of the two techniques is petticoat capsule flap transposition. Let us take a look at the operative procedures. Firstly, expose the posterior capsule entirely from upside to the lower part of the femoral neck. Secondly, cut the inferior 2/3 of the posterior capsule near the ischial attachment of the capsule, and then rotated the capsule to get to the greater trochanter. This just like a petticoat flap transposition. Thirdly, transfer the free end of the capsule to the great trochanter, just showed in the video. Finally, fix the capsule to the great trochanter with earthbound suture. We can see these capsule structures after reconstruction is very similar at the ischiofemoral ligament, zonar orbicularis, and spirofibrous. This video shows the stability test of the hip in extension. No dislocation in the internal external rotation. And the inflection, neither dislocation occurred during internal external rotated. So it's very reliable method to stabilize the hip. When the capsule is not enough to be transferred to fix to the great trochanter, we can select the second technique, reconstruction of the posterior capsule using mesh. Mesh has reliable strength and a little bit elasticity. Therefore, it has already been used to reconstruct the ligament and important muscle function in hip and knee revision, and has achieved good result. The left picture just shows reconstructing the extensor in revision total knee arthroplasty with mesh. The right one is reconstructing the function of abductor using mesh. So we use mesh to reconstruct the posterior capsule in total hip arthroplasty. Firstly, mesh can be prepared to a V-shaped structure. This structure is just like ischiofemoral ligament of the capsule. The tip of the V-shaped structure is fixed to the capsule with sutures. The red picture just shows the mesh has already been sutured to the capsule. This video just shows the two branches of the V-shaped mesh structure can be fixed to the greater trochanter respectively. After the capsule was fixed to the great trochanter, the piriformis was also fixed to the great trochanter. The red pictures show the piriformis covered the mesh and fixed to the great trochanter. This video just shows the test stability of the hip intraoperation. We can see it's very stable in full range of motion. These are intraoperative videos. The hip didn't dislocate even in extreme flexion, abduction, and internal rotation. From this video, we can see just like a native capsule, the mesh structure also acts as a hoop to effectively prevent the hip dislocation. This is a female patient with necrosis of femur head, and she has a polio with weak muscle strength on the right leg. So she belongs to a high-risk case. After implanting the prosthesis, we reconstructed the capsule by using mesh. This is post-operative X-ray and walking gait, 3 days post-operation, and the 2 years follow-up, no dislocation occurred. This is clinical study. By now, we have performed 15 cases with these two techniques. 9 cases are femur neck fracture. 3 cases are femur neck necrosis with polio, and 2 cases are revision total hip arthroplasty. We use pedicle capsule flap transposition for 9 cases and use mesh for 5 cases. Average follow-up was 18 months. No dislocation occurred at final follow-up. Take-home messages. These 2 techniques of posterior capsule reconstruction are all simple but effective. They are reliable and valuable for increasing stability of total hip arthroplasty, especially for the patient with higher risk of dislocation. It is a little bit time-consuming for using mesh to reconstruct the capsule. Thank you for your attention.
Hello, my name is Dr. James Slover from NYU Langone Medical Center, and it's my pleasure to be with you today. I only wish we could be doing it in person. I'm going to be speaking about the application of dual mobility in total hip arthroplasty. There are some disclosures, but they're not relevant to this presentation, but you can find them at the AAOS website shown here. So total hip arthroplasty continues to have issues with dislocation. The dislocation rate has been reported to be between 0.5 and 9% for primary total hip arthroplasty, and being between 2 and as high as 27% in revision total hip replacement. If you look at the epidemiology of revision for total hip arthroplasty in the United States, you see that dislocation is the #1 cause for revision of hip replacement. This is one of the most frustrating complications of primary and revision total hip arthroplasty. Patients are often dissatisfied and often view this as a surgeon error. It can stress the patient-physician relationship, and it has significant costs to the healthcare system of up to $74 million in the United States alone. There are multiple risk factors for dislocation after total hip arthroplasty, including obesity, which some have shown has no increased risk of dislocation, but others have shown does have an increased risk. Taller patients seem to be at higher risk than shorter patients. Females have a higher rate of dislocation than males. If the primary diagnosis is femoral neck fracture compared with degenerative disease or arthritis, the risk of dislocation is much higher. If you're doing conversion total hip arthroplasty where there's been previous surgery, the dislocation rate is higher due to abductor dysfunction, bone loss, or perhaps deformity or other factors. As patients age, the rate of dislocation increases as well. And if patients have a collagen or a neuromuscular disorder, the risk of dislocation is also increased. Lastly, non-compliance with activity restrictions or range of motion restrictions increases the dislocation rate as well. There are surgical factors as well, including the approach, the soft tissue tension, component positioning, impingement or offset, head size, liner profile, presence or absence of capsular repair, as well as surgeon experience, all of which have been correlated with dislocation after total hip arthroplasty. There are 6 categories of instability, including malposition of the acetabular or femoral component, abductor deficiency causing dislocation, impingement, polyethylene wear that's late, or those that have unclear etiology. So I want to talk a little bit about head size before we get into the specifics of dual mobility. Larger heads have a theoretical advantage of greater range of motion to impingement. They can allow you to avoid skirted components, and they have a greater jump distance before an actual dislocation occurs. Larger head sizes have been shown to have lower dislocation rates in primary total hip arthroplasty. They also have lower dislocations in revision total hip arthroplasty. So the use of larger heads is one tool to reduce dislocation rates in both primary and revision total hip replacement. Liner options exist that also can help reduce the risk, including elevated or lipped liners, lateralized liners, which will protect against dislocation in some instances, but you have to be careful how you use them as well, because if they cause impingement, they can actually cause a dislocation as well. So there are different types of heads, including the standard hip replacement shown on the left, a bipolar or constrained type shown in the middle, and dual mobility shown on the right, which is what we're going to talk about today. Again, dislocation rates have been shown to be between 1 and 9% for primary and 9 to up to 30% for standard hip replacements. Dual mobility has been shown to reduce the risk of this to 0.9% or 0.09% in one study, and even in revisions to less than 5%. The principles of dual mobility include multiple factors. There's 2 heads through dual mobility. There's the inner smaller head and the larger external head. The large external head increases the jump distance before a dislocation occurs. In addition, there's increased range of motion created by the inner head before you have impingement that can cause dislocation. In addition, there's a decreased lever out effect because of this additional range of motion, and the second articulation creates. So what are the indications? Well, I think high-risk patients for dislocation is the indication. And again, this shows the jump distance difference that you can have for a typical head. When you go from a 14 millimeter jump distance on the left with a standard hip replacement and a dual mobility cup of the same size moves to a 23.5 millimeter jump distance. This can markedly reduce your dislocation rate. There are concerns with dual mobility as well. There are concerns about intraprosthetic dislocation of the inner and outer head or of the outer head from the cup. There's concern for excessive wear due to the multiple articulations. There's some concerns for adverse reaction to metal debris that may be created. As you see in position 2, there can be impingement along the head that may increase this. And this impingement can also potentially lead to one of these intraprosthetic dislocations. These intraprosthetic dislocations can be missed because the stem may still appear to be inside the cup due to the presence of the inner head. Shown here, you can see there's a subtle soft tissue sign of the outer head, which has dislocated from the inner head. And you can see that the stem is not centered within the cup. But sometimes they're more subtle and difficult to appreciate. So you have to make sure there's a careful examination after a potential dislocation or after a reduction of a dual mobility head, which sometimes can be achieved in the emergency room without surgery and other times cannot. If you do get an intraprosthetic dislocation, of course, this will require surgery for the patient. The incidence of this has varied. It's approximately 3%, but there are studies that have shown no intra-articular or intraprosthetic dislocations to as high as 5%, with an average of approximately 3%. Again, these may have a biased sample in that they often may be used in the higher risk patients, but nonetheless, it shows that intraprosthetic dislocations can occur. And so using a dual mobility still requires careful positioning of the implants. There have been concerns for corrosion by creating another metal interface if you use a modular dual mobility, as shown here on the right, where there's a typical outer shell with the ability to put screws in. There's then an inner metal liner, which creates an extra interface that can generate metal debris. Here are some studies showing cobalt levels have been increased in patients with dual mobility constructs, and the clinical consequences of this are still yet to be determined. I wanted to talk briefly about dual mobility and revision total hip arthroplasty as well. Dislocation has been shown to be a significant concern in the revision population for many reasons. Sometimes implant positioning is impacted by the ability to have adequate bone stock to position the cup where you would like. There can be more soft tissue concerns related to having previous surgery, and dislocation can be a significant risk factor with revision surgery. The use of dual mobility did reduce this in this study to between 0 and 3.7%, which for revision population is a low rate. Can dual mobility prevent dislocation in all situations after revision? This was a study that shows that at 7.3 years follow-up, the dislocation rate was 1.5%, and there was an intraprosthetic dislocation rate of 0.2%. The two intraprosthetic dislocations occurred in acetabulonary revisions and may have been related to head-neck ratio with impingement. So just because there's a dual mobility in place, you still need to make sure that we carefully position the implants and avoid impingement, which can lead to either dislocation or intraprosthetic dislocation. Another indication for dual mobility includes the use or the salvage of monoblock metal-on-metal acetabular components. Shown here is a hip resurfacing in need of revision. Rather than remove the acetabular component, which is well fixed and can be quite destructive to bone, you can apply a dual mobility head to a femoral stem and salvage this case. You still have the risk of intraprosthetic dislocations, so you need to make sure that you're positioned carefully. And this has been shown to help with metal ion levels in cases of impingement as well. Regardless of what type of prosthesis you're using, dual mobility or standard. I still think that dynamic hip stability testing needs to be the ultimate test in the operating room theater regarding the stability of a hip. There are 7 things that I check routinely in every hip to assess stability. I want the patient to be stable in maximum flexion with no evidence of subluxation. At 90 degrees of hip flexion, I want them stable to internal rotation. I want them stable for internal rotation at 45 degrees of hip flexion. I put them in position of sleep and make sure they're stable as well. And then to check anterior stability, I do adduction and then external rotation, followed by extension and external rotation, which is the more common way to dislocate anteriorly. And even if you do a posterior approach, I think you need to check for anterior instability, especially if you use a lip liner, because impingement can cause anterior instability. And the last thing that I check is leg length to ensure that we haven't shortened the leg as far as stability. And of course, we don't want to over lengthen unless we need to for stability reasons. So I think that dynamic hip stability testing is still the most important step, regardless of what type of hip you use. So I just wanted to show a few cases where we have used successfully dual mobility. This is a patient that obviously has a very stiff spine, having had a fusion that includes fusion to the sacrum and pelvis. Here's showing some EOS films showing very little motion in the hip as expected, given the hardware that's in place. Here are the sitting views as well. You can see the hip on the right side there is very severe. We treated this with a dual mobility cup. We used extra screws given the superior bone loss that was there, but we were able to treat this patient successfully with no instability. This was a modular dual mobility cup. So again, you see the screws to secure the cup, and there's a metal liner, and then the dual mobility head sits inside the metal liner. Here's another case that's high risk patient. You see there's a femoral neck fracture in a rheumatoid arthritis patient. There's also spine hardware indicating likely a very stiff spine. Patient underwent initially a standard total hip for femoral neck fracture using a standard head and liner. The patient then needed extension of the lumbar fusion, which decreased the range of motion in the spine even further. This unfortunately led to a dislocation of the hip, as shown here. There was a closed reduction performed in the emergency room, but there was another dislocation shortly thereafter. The patient then underwent a revision using a dual mobility liner, and again, using a modular cup due to bone loss so that screws can be used to gain fixation. And then the polar liner sits inside of the cup, and then the dual mobility articulation is used on the femoral stem, which was retained. So as far as instability, I think the most important thing is to try to address it during the primary, because the risk during revisions will be even higher. If you're revising a hip for instability, make sure you solve the problem. Even with a dual mobility head, you can't have impingement. Cups need to be positioned appropriately. You need to have appropriate offset and soft tissue tension. You need to assess your dynamic instability using the 7 things or the 7 methods that I reviewed. If you're revising the hip for other reasons, you still need to be very careful about instability given the risk of dislocation. And dual mobility has been shown to be an effective tool for decreasing this very difficult problem in both high-risk primary surgeries as well as revision surgeries. So it's something that you should consider in these type of cases. Thank you.
Thank you to our 3 speakers for their wonderful talks. We have a panel discussion now. Do we have any questions from the floor or from any of our discussants? If not, I will kick off the first question to Professor Stefano.
I have questions. Okay.
Go ahead, please.
Yeah, I have questions for the team Slover. As we know, there are 2 options for the high risk dislocation patient: dual mobility cup and constrained liner. Yes. What do you? How do you select this different cup? This different method? Do you have some candidate patient?
Yeah, I think right now, I don't know that that's clearly defined. And I would say that in general, I try to use dual mobility rather than a constrained liner because I have concerns about impingement with the constrained liner, and especially in the revision scenario, the subsequent loosening that can occur. And I've really had success in many cases that traditionally I would have used constrained liner by using the dual mobility. I think the one exception may be somebody that has complete absence or really no abductor function at all. That would be the one patient that I think a constrained liner, may be needed if there's literally no abductors. But if there's any abductors, even if the trochanter is fractured but the sleeve is intact, I will use dual mobility as the first line and constrained liner only if the dual mobility fails. I've had some cases even where I used constrained liners and they kept ripping out, and then I went to dual mobility and they did okay. So I tend to use dual mobility much more frequently than constrained liners now.
Yes.
Just to add something to that, James, do you agree that the other indication might be neurologic? Yeah. More muscular detachment, but neurologic dysfunction?
Yeah, and so I would just group that in. Yeah, if there's a complete, there's no function of the abductors, whether it's structural or neurologic, that would be the one, patient that I think sometimes a constrained liner is needed. And you're right. So sometimes it can be a neurologic dysfunction, but for me, it really has to be complete dysfunction of the abductors for me to do the constrained liner, or failure of dual mobility, and I'm trying to salvage that.
Okay. I have a question to Dr. Slover.
Sure.
As I know, we have two types of modular dual mobility articulation available now. One is the hemispherical, and the other one is cylindrospheric. So do you explain the advantages or disadvantages between the two different type of modular dual mobility articulation?
Yeah, I think that there's going to be, we don't have that information. I do think we have to be very careful as to which one may be better. The advantage of one is that if you provide more coverage, the jump distance in theory is increased, but you potentially expose the implant to more impingement by having over coverage of the dual mobility head. Which one is going to end up performing better, I think remains to be seen. I don't think we have data for that. And I think we have to be very careful when we're thinking about all the literature reports on this. The term dual mobility, sometimes everything gets lumped together, but there are different designs which may have different results, as you say. And even the modular and non-modular may behave differently and have different results in different scenarios. The obvious advantage of the modular is if you need to, you can put screws. So in the revision scenario and so forth, sometimes that's necessary, but you lose head size. You create a metal interface by doing that. And you also get a smaller head than you would with a non-modular by doing that. And so comparing all of these things sometimes can be a little bit like comparing apples to oranges. So I think we have to be very critical about that. And as far as the two modular designs, again, I think the jump distance versus the impingement, and I'm not sure we know which one is better at this point.
Thank you very much.
I'll ask a question to Professor Stefano. So the question that was asked to Professor James was kind of a prelude to this. So you do gluteus medius repairs, even for total hip replacement patients. How do you assess the stability of the total hip properly before you repair the gluteus medius? Because usually you repair it after. And how do you routinely use constraint or dual mobility liners for these patients, or do you do a standard conventional lip liner, standard liners for your patients who require gluteus medius type of repairs?
That's such a good question. I've never used a constraint or a modified cup simply because the gluteus medius was torn. The attachments are quite snug. You have, when you repair the gluteus medius down and you do that release on both sides of the tendon all the way up to the iliac wing and then pull it down and attach it, you're not going to be worried about instability. It's a very snug repair. And another reason I don't, I use a mesh to support it because I know there's a lot of tension on that repair, and it's not an area that wants to heal easily. But it just hasn't been an issue. The one patient that did dislocate, it didn't have to do with the abduction. It was to do with the position of the components. And he was a 3 or 4 time revision case. There's no posterior capsule. I could have used the technique that was just shown to reconstruct the posterior capsule. I thought it was quite good. But yeah, it's not an issue that I've ever had to deal with, actually. I find that the repairs are quite solid and the patients are not unstable even at surgery.
Right. I'm just more concerned about how do you establish the proper offset, the kind of soft tissue tension
right.
by putting the hip before the medius repair.
Yeah. So these are not people who coming in for instability or dislocation because of their adductor deficiency. They have hip pain. They often have had a hip replacement through an anterior lateral approach. One of my former partners did a lot of them, and I've done a lot of repairs. So I got very good at it, but those people are not unstable. They just have about a third or half of their tendon gone. The ones with this entire loss of the attachment of the gluteus medius or at the trochanter, if they've had a hip replacement, they're not coming in for instability. They're coming in for metal ion issues. They're coming in for something other than that. As a result of my experience, and your question also made me realize it, is I'm not convinced that that the abductor is the principal stabilizer of the hip the way we normally think about it. You got all the abductors are still attached to the femur. You got the flexors attached to the femurs. You got the extensor, the IT band. All that is quite stabilizing, and I just do my hip replacement as I need to do. When I'm done with it, I finish up with the gluteus medius repair, and then I put them in walker for 3 months. Yeah, good question though.
Thank you. Question from the floor.
I have a question.
Go ahead.
Dr. Zhang, did you regularly repair every primary THA posterior capsule? Everyone regularly?
Yes.
When will you choose a mesh to repair that?
Yes, because I usually use the petticoat capsule flap transposition, because this is not time consuming, so it's very easily and quickly to reconstruct the capsule. As far as I know, most doctors do not pay attention to the reconstruction of the joint capsule, but go more attention to the piriformis. So the literature side from the literature, the result describe the capsule reconstruction is more important than piriformis for the stability. So I always reconstruct the capsule. Use this method.
Yeah, thank you. I agree with you. I will always repair the capsule for every primary THA.
But in general, if we reconstruct the capsule, just let the leg in external rotation and extreme abductor. But if you return the leg in a neutral position, always the capsule will be avulsed, will be teared. So the paper has demonstrated the maybe 75% will be failed after operation.
Yeah.
After reconstruction.
Yes, good point.
Thanks. There's a question from the audience, which I think I can direct to Dr. Stefano and Dr. Chang regarding use of a mesh, long-term problems, complications, adverse reactions, fibrosis, etc. Do you see any of them in your practice?
Yes, maybe this question, but mesh has already been used to the reconstruct the extensor in revision to the knee and reconstruct the abductor, just Professor Stefano side. So maybe this question, but I don't know the real issue. Maybe this is in the long run questions.
I agree completely with Dr. Zhang. There has been almost no incidents of in my hands or that I've written about any kind of problem with the tendon. As the mesh, this is not a resorbable mesh that creates particulate debris or some kind of a material that can be inflammatory. What happens in the tendon is that it becomes a scaffolding. So I'm sure that Dr. Zhang as well if he goes back, you don't see the mesh anymore. It becomes completely enclosed with fibrous tissue, bleeding tissue. It's actually healthy tissue that interweaves itself around the mesh. The mesh is simply a scaffolding. And so I don't think it has a tremendous amount of tensile strength until it is integrated with the scar tissue above and below, in my case, connecting the vas lateralis to the gluteus medius and unburdening the anchors, because you don't want all of that pressure just on the anchors. You want to transfer it across. Earlier with Dr. Lim's talk about the tendon, I just want to make one more point. There is when we talk about the psoas tendon, it's more common a problem in women. The gluteus medius tears are also a more common problem in women. And it's because of the anatomy. And it's been shown, people have been talking about the girdle-trochanteric pain syndrome, that the amount of force required for abduction in women because of the shape is 35% higher than in males. So there's simply more tension on that attachment, and it just degenerates and it needs to be supported. What the mesh does, it creates a scaffolding for the ingrowth of tissue to create that and to create the linkage from the muscle back to the tendon.
Yes, I'll agree with that.
Thank you. A question from the audience for James. You're asking, why does the femoral neck fracture patients have a higher dislocation rate, in your opinion?
Well, I think that because many of them haven't gone through the slow osteoarthritic process that involves scarring and stiffening, they have much more range of motion right before their surgery. And, as a result of that, I think that's one factor. I think the other factor is that there's often many cognitive issues that may have come into play as to why those patients achieved the femoral neck fracture to begin with. And so that may impact how they rehab afterwards. That may also increase their risk for dislocation. And lastly, there's a lot of tissue damage to the capsule and other tissues that can occur with these fractures. And so the repair may not be as stout as it could be with an osteoarthritic primary.
Corey, you're trying to say something, Corey? Any other questions? I think there's, go ahead.
No, I was going to ask if the gluteus medius repair, there's almost no literature on it. We just did a research. There's maybe 20 decent articles on it. There's almost nothing done on the pull-out strength of the anchors, almost nothing done on the sutures. It's something that in the 80s was abandoned as a procedure that didn't work from the anterior lateral surgeons. And I'm just curious if in China there's an understanding of this pathology, and if you commonly repair them, and if you have any suggestions for us. In the United States, I think it's poorly understood, often ignored, and usually overlooked. And it's unfortunate because these are some of my happiest patients when we finally fix them. I can get rid of the pain almost in everyone. The function I told you is based on the fatty degeneration, and nothing else works. The gluteus maximus transfers are a disaster, and there's really no other good option. But I'm curious if you have anything to add to that conversation, because I'd love to learn more. Any of the speakers.
Mr. Zhou, Guoqiang,
Dr. Zhang, or
I would say we do have many of these kind of patients, but just as you pointed out, we don't have any articles or research about that. It's totally empirical. So different surgeons have different repairing techniques. But personally, I use a similar technique you just described. So I think the augmentation with a mesh is important.
Yes, maybe in China, so many surgeons always use the transfer maximum gluteus transfer to substitute the medial, the gluten medials.
But I don't think it works. Most people have published say it doesn't work. It shortens the muscle. It has no abductor length. It has no functional capacity. It moved up that far. It just is too long a muscle. It covers a trochanter, but you don't need the gluteus medius for that. I think we published 2 papers of about 50 cases, and it was like the second largest series ever published. So if you guys do some of these, or hundreds of them probably, it'd be great to have you contribute and maybe bring them to AAHKS and teach us your experience, and would love to hear from them. Yeah, so that's great. I was just curious. Thank you for indulging me on that. I think it's these are just happy people.
Yeah, I would say probably it's important to our audience. It's not only about refix the gluteus minimus tendon to the greater trochanter again. Another issue is also important is to restore the continuity between gluteus medius and the femoris lateralis. So once you restore the continuity of these structures, the tension of, the tension of soft tissue envelope around the hip actually maintains the hip stability.
Corey and James, do you have anything to add to that?
Yeah, I was actually muted earlier to tell the kids good night. So sorry to all participating. Yes, I was curious specifically about the incident. So, it sounds like Dr. Lim and his mentor, there's a lot of anterolateral approach in your area, which is wonderful. I certainly did that in training. But the speech I always gave my patients was about 1 in 100 limp. What are you seeing at your volumes? Is it higher than that? Is it lower than that? And we just don't know how to do that approach. I think that's really getting what Dr. Bini's getting at. It's not a common problem because we're seeing less of that approach, or at least around where I am. And I assume, Dr. Bini, you've seen a decrease in that over time, it sounds like. But what do you all see as far as incidence?
So let me ask that question as two differently. One is the iatrogenic, and one is simply a degenerative tear. I think we're missing a lot of degenerative tears, just like the rotator cuff. So the degenerative tears are just trochanteric. People who come in with trochanteric bursitis, you do an injection, it comes back right away. They're not really that tight on the IT band. It hurts like hell right there. That's a gluteus medius tear until proven otherwise. If they have a limp, then it's a big tear. And then there's the surgical ones. So we just have never looked for these. We're not aware of them. We just think it's bursitis. And I'm telling you, it's not bursitis most of the time. Sorry, but the surgical one, I don't have a good answer for, because I think we've learned how to sew it up better than, and I think you're right, Corey, there's not as many as there used to be in this account over here. What's your thinking, Dr. Lim, about that?
Oh, yeah, this is very difficult to answer, but because my routine approach is anterolateral approach, when I approach the hip, especially in elderly osteoarthritis patient, I frequently saw the minimus tendon is partially ruptured, but I experienced very little instance of medius rupture. So I think gluteus minimus partial tear are frequent in elderly osteoarthritis patient, but medius tear is rare in the native hip. But in revision situation, you know, the resurfacing, the matter problem or kind of multiple surgery makes, you know, no medius attachment to the GT. So next time I will try to your technique. This is, you know, amazing. I never thought about the, you know, that kind of repair. I just do the white side technique, the maximus transfer for the medius absence, but your techniques maybe looks very amazing. So next time I'll try it. Thank you.
Thank you.
Thanks, everyone. I just got one last question from the audience so that we can move on. James, this is addressed to you as well. Is there any difference in the dislocation rates comparing large diameter jumbo cups and head versus the dual mobility in revision total hip?
Yeah, so I don't know that we have great sort of head-to-head studies on that. I think that we do know for sure that larger head sizes have reduced instability in both primary and revision total hip. And I don't mean to imply that I think every revision needs a dual mobility. I think if you do a revision and you are able to do your dynamic stability testing and you have good abductor tension and you've restored offset and length, a large head, you know, may work very well in a lot of revisions. I think the dual mobility helps you in the higher risk revisions where either due to bone stock issues, potentially the cup position is challenged and not exactly where you would want it from a stability standpoint. It helps in situations where the soft tissue is challenged and perhaps the abductors are not functioning as well as you would like, or they're partially damaged, or you can't quite restore the offset that you might want to. Dual mobility may help in these scenarios, but I don't mean to imply that you need it in every revision. And I think, you know, careful analysis of that during the case, it's just a tool to have in the toolbox. But I'm not aware of head-to-head studies on that, but we do know that as the head gets larger, the dislocation rate goes down. That has been shown.
James, you want to address the corrosion question that was also in that?
Yeah, so that is a concern. I mean, I touched on it briefly in my talk, especially in the revision scenario where you're very likely to be using the modular dual mobility. We have seen some studies reporting metal ion levels are increased. What the clinical consequences for that will be or could be, I don't think we know yet. Whether that can cause a soft tissue reaction like the trunnion and trunnianosis long-term, I think remains to be seen. But I think this is one of the reasons I would say it should not be used in all cases if it's not needed. I think it should be used in cases where you can't achieve stability with a more typical bearing surface and you need that extra stability.
Mm-hmm. I think most of the data on the corrosion was from poorly seated liners, right? I don't think there's much of anything on well-seated liners, or is there?
I don't know that we know that. I mean, there are some studies just showing, you know, that there are some metal ions generated in dual mobilities, and whether all those liners were, or some of those liners were not seated properly, I think we don't really know that. So I think it's a concern that could be out there. I don't think it's a definite problem yet, but it's something we need to watch and follow. And I think it's something to consider when you're considering your implant. But I think stability trumps it. I don't think it's strong enough that I would accept a hip that's not as stable as I would like. I think stability trumps it, at least right now, for what we know.
Regarding the metal ion elevation, in our country, as a PI, I do prospective randomized clinical trial for the metal ion elevation, but our inclusion criteria is only for primary and more than 65-year-old people. So currently, in our hospital data, they have no elevation of metal ion so far. So I personally use the dual mobility, modular type dual mobility articulation only for ages more than 65 now in our hospital. Yeah.
And you've seen no elevation, and those were modulars? I mean, that's good.
Modular MDM, but the more than 65, but our hospital only 25 patients, but so far no elevation. Yeah, within normal limit. Yeah.
But Dr. Lim, what's the rationale for limiting the age to 65?
That's only for the clinical trials. So we have to make a kind of inclusion or exclusion criteria. So personally, in our country, 65 is in retirement ages. So I just cut off, 65. Yeah, there is no reason, just elderly.
Okay, thank you, everyone. We're going to move on to the next section whereby Corey will be the second last speaker. We'll be talking about robotic total hip cases and beyond. Thanks, Corey.
Yes, thank you. Thank you so much. It's great to be with you. I was really enjoying just sitting and hearing the panel. I wish there was an opportunity to interact perhaps better with our audience, but certainly I would echo what has been said. If you have questions, please drop them to us. Certainly, I drop my contact into the chat. I'd love to connect with you all personally in any way. So just a few minutes, I thought we would talk a little bit about these robotic cases that I mentioned earlier, a couple of demonstration cases, and then just for fun, a large acetabular revision. Due to our format here, it's hard to make it interactive during my talk, but I'll try to briskly move through, hopefully irritate and stimulate some conversation. And well, you can tell me what I did right, and more importantly, what I did wrong. My disclosures are no different. I'd like to demonstrate just a couple things here, a robotic workflow. We'll talk about that a little bit in the first and second case. Robotics is not used in the third case. And then ultimately, I invite your critique, and I'd love to hear how we approach these problems different. First of all, what I'm not going to talk about is these disaster cases. I have no idea how that could possibly happen. It was probably on the West Coast, Beanie, don't you think? No, all kidding aside, there are devastating things that can happen with surgery. I'm not even sure this is real, but if it is, at least the hip is located, which is good. No dislocation here, guys. No dislocation. And I actually fear that this is actually a real case, and I'm just not totally sure how that happens. But we're not going to talk about those cases. Nothing quite that interesting or concerning. Instead, we'll talk about, again, two robotic cases quickly, and then finally a complex revision type case. This first case is a 46-year-old male, previous acetabular fracture, which you can see the hardware. Obviously, this was a posterior approach. If it was more of an open format, I'd like to see how you work these up here in the U.S. Obviously, ruling out infection, very important for us with lab work. And for me, almost always aspiration as well. Essentially, it's hard to plan these cases, and you have to go in on these cases knowing that you have a metal cutting burr, and you don't really know how many screws or how many plates you're going to have to take out. I've actually moved now to do most of these cases anteriorly if I don't have to take out much hardware. So we'll talk about that a little bit later. You can plan this in 2 dimensions. This is just a digital planning, obviously screen, and many of us would. But again, we really don't know where all that hardware is. But this is the Mako platform. So preoperative CT scan, you're able to plan your cup and stem. And you can see exactly, in this case, we removed the second screw on the first plate, and that's all we did. This is, again, stem planning, which we'll talk about a little bit more. This is how it should look when you're done. This is a simulated X-ray view. So really, we're trying to figure out exactly what we want our final result to be. But the power here is knowing preoperatively which screws you're going to need to remove and how to do that. Again, nowadays, this was a case done posteriorly, a large removal of heterotopic bone, obviously, to get in there. But I would now do this case anteriorly. I would have taken out that one screw. I'd be in virgin soft tissue planes. I'd single stage ream. You can see how this patient ended versus what the plan was. Obviously, the execution of the plan is what we talked about with some of the power of the robots. Now, this case 2 is a stiff spine. This touches on a lot of what we've talked about today with regard to a stiff spine and the challenge of finding that cone that I thought Ran articulated so well. So a 62-year-old female, right hip arthritis, maybe not the worst ever, still fairly flexible as far as her hip motion. Her BMI is 18. These are those spine films that we keep talking about. So standing and sitting spine films. Note that this patient is not fused, right? It's not an instrumented fusion, but the spine is quite stiff with really minimal change in the sacral slope in standing and sitting films. Again, you can plan two-dimensionally with regard to cup size or even on acrylics, which I still like to do because I love the smell of the markers, but ultimately you don't know three-dimensionally how to plan out this case until you get a CT scan. You can see several things here. You know, we've talked a lot in the topics earlier, the talks earlier about iliopsoas impingement. Here in the three-dimensional world, you can make sure that that anterior rim of the cup is inside the bone. You can perfect the verticality. And again, putting that information in the standing and sitting films, remember, this is a very stiff spine. You can not only get these really interesting numbers down here at the bottom of the screen. Sorry for that, jumping all around here. Here we go. So these really interesting numbers down at the bottom of the screen. Again, the question was asked earlier, the supine position of the pelvis versus the standing position. And you can see how the cup changes between those two. But in this patient, from standing to sitting, really not much change in the pelvic position. So we know that this is going to be a fairly narrow, safe cone, if you will. This came up earlier too, so I'm glad I had this in here. This is planning on the femoral side. Remember, I think it was Stefano that mentioned, hey, you know, sometimes the femoral side is really a problem. Notice here in this version of the software, this is that 4.0 software, which actually I'm going to release to everybody on this call tomorrow. So congratulations to everybody. It'll be our parting gift from the US. Now, I wish that was the case, but you can see the femoral version here is 9 degrees, but the stem version is actually 18. Once you fit that stem into place with the bony constraints, you're actually going to get more version out of your stem than you did natively. Nonetheless, you can take these through the range of motion. This is that simulated range of motion that we're talking about. This patient, when the patient flexes to 90 degrees and internally rotates here to 61 degrees, you can see the extra implant, so the bony impingement, which is shown in red, and you can decide to make little tweaks to your implants to help accommodate this. You could increase your version, as we've talked about, a very powerful tool to help some of that bony impingement. Same thing here. Now in extension, you can see standing is simulated here, 10 degrees of extension, 16 degrees of external rotation, just barely any touch of the bone there. And again, just another one showing, you know, obviously the more you externally rotate this one to 27 degrees of external rotation, you get that bony impingement. Intraoperatively, it's so important to take the CT scan, match what you see, and that's what you see here. Obviously, you're going to ream, you're going to put the cup in just as you planned, again, with those micro adjustments. Make sure your stability is increased. You know, dual mobility, we've talked about a lot. This is some data from the AJRR. Dual mobility here in the US is used more and more, but we've talked about some of the potential concerns with these designs. You can see the high utilization up to 10% if you're over 90 undergoing primary revision. This is some of that literature on not all are seated well. And actually there's some data that says, hey, large heads may do as well as dual mobility. So we can argue about this when the time comes. Now just a quick case. This is one of those cases that hopefully we don't encounter too much, but this is a patient that underwent staged total hips in 2001, a revision on the right in 2016, and came in with right hip pain. Now notice here, nothing too fancy about the stem. We end up saving this stem, but notice the position of the cup here, right at, on the inner aspect of the pubis there. So this was July of 2019 when she started to complain of pain. She didn't want to explore surgery. This is September of 2019. You can see clearly that cup is migrating into the pelvis. She still didn't want surgery. This is December of 2019, and you can see we have at this point a major problem. In this case, I elected to do a custom tri-flange type component. In order to do that, I did a CT scan, and you can see this 3D model in front of us. You can flip and spin any way you want. You can see the defect. The red area there is the bone that I'm going to remove to fit this tri-flange component on, which you'll see here in just a second. It will go into place. And even the screw trajectory in this system, you can decide locking versus non-locking screws. Those are the locking screws. Those green screws are the non-locking that go up into the dome. And the good thing about this component is you can match your version, and you can snap a liner directly in this for improved stability. And this is what it looks like. You can actually have them send you a model too if you don't want to play in the digital space and kind of put your hands on it, which is great. So this is what she looked like in December 2019 when I ordered the CT scan. Obviously, it took about 8 weeks to build the custom implant. And this is what she looked like 3 months later. This was at her pre-op visit. Now we've got a big problem. The pandemic hits and she gets pushed another month, obviously, before we do her surgery. Unfortunate circumstances. This is me intraoperatively. Obviously, the cup's gone. These are the initial screws in the tri-flange. I end up constraining all of these. And so there's our tri-flange reconstruction, bone graft behind, largely locking screws, except for these three that go into the iliac wing. What's the cost of an implant like this? This one was 13. This is actually this patient's implant cost, $13,000 US, which you can see is nearly 85,000 for my Chinese colleagues, and almost 10,000 in British pounds. So custom tri-flanges. Yes, reoperations can occur for infection, screw removal, and asymptomatic loosening. This is a series of 50 patients. 3 others were radiographically loose, but with a 12% dislocation, that's why I tend to constrain them. So here's the key takeaways. Technology can be a tool even in complex primary cases. Careful evaluation for instability patients or those at risk for instability. Custom tri-flanges are a powerful tool. Feel free to scan that image to connect with me. But really the main takeaway is make sure you hire a junior partner. Thank you all so much for having me.
I am your final speaker for today. And it's been a great honor to be invited to this prestigious faculty of esteemed, renowned professors in the realm of this extremely difficult topic as well. Instability and leg length discrepancy. My talk will be on a case presentation on ankylosing spondylitis with a stiff hip for total hip replacement. I am an assistant professor, and I'm also the ERAS TKR clinical lead for my hospital, the chief of the adult reconstruction service, and as well as the core clinical faculty member for the NHG orthopedic residency group. And this is my hospital background. It's the second largest public tertiary hospital in Singapore. And this is going to be my Zoom background as well. It's founded in 1844 with 1,700 bed and growing. And we are also part of the National Center of Infectious Disease, which has a growing international recognition for management of the COVID patients. Okay, so I'll go on to my case discussion, and very nicely that the earlier presentations from Professor Rand, Corey, and James have led to this final case presentation. And I have this gentleman who is 59 years old. He has ankylosing spondylitis, and he has had his left total hip replacement done in 2000 at the age of 39 years old. He presents with a worsening right groin pain, and that's his x-rays. Pre-op pictures shows a 20 degrees fixed flexion deformity of the hip with a restricted range of motion and about 1.5 centimeters shorter. These are his pre-operative videos. He had to turn in blocks. He had to have a pillow under his head and difficulty getting in and out of bed. That's his gait. With obviously antalgic gait and a shortened right lower limb. That's his x-rays of his cervical and thoracic x-rays, which shows kyphosis as well as ankylosis as part of his disease. And that's the lateral x-rays that we have been talking about, supine to erect to sitting, and shows some spinal pelvic movement, but certainly much lesser than the normal. That's the anterior pelvic plane as well in 3 different positions. Just point your attention to the standing anterior pelvic plane, which indicates minus 17.2 degree posterior pelvic tilt. That's to compensate for his thoracic kyphosis. And obviously, we go back to the X-rays, as what had been mentioned earlier in Professor Rand's talk. This is an outlet view, although it's taken in an AP direction, and that's suggestive of a posterior pelvic tilt, exaggerated posterior pelvic tilt. And then if we measure his other parameters, which includes the lumbar lordosis as well as the pelvic incidence, we find that he has got a flat back deformity with a PI to LI difference more than 10 degrees. We had a CT scan in planning for Mako, total hip replacement, and we find that his native right hip is about 28 degrees anteverted, and his left side is about 20 degrees anteverted left side, whereby he had his left total hip replacement. And for the right side, his native femoral version is about 5 degrees. So should we treat him like a stiff spine patient going for total hip replacement with risk of anterior impingement and posterior dislocation? Or do we treat him with like a ankylosing spondylitis, which have problem of progressive kyphosis and exaggerated posterior pelvic tilt, and therefore risk of anterior dislocation? Next thing to think about, if you are competent in both approaches, which approach for this patient? So a screenshot from Professor Rand's slides earlier, and I will classify this patient as under here a flat 2B with flat back and a stiff spine. And using another type of classification, this patient will be more like a stuck sitting kind of patient with the sacral slope less than 30 degrees in both sitting and standing, therefore putting him at risk. That's the picture of a progressive kyphosis in a problem of ankylosing spondylitis. And we know from his posterior pelvic tilt that he has, which shows an outlet view in an anterior posterior directed X-rays. Therefore, the thoughts for this patient are, well, he's at risk of, he requires increased functional acetabular active version to avoid anterior impingement while sitting. But there's a risk of dropout anterior dislocation while standing, if the cup is too anteverted. The opposite total hip replacement 20 years ago served him well, can follow, and similar parameters. But the native femoral version was only about 5 degrees, although we know we can increase probably by up to another 10 degrees during a surgical instrumentation using a uncemented stem. So the thought is to compromise between a 20 and 28 degrees of cup version, putting him about 25 degrees. That will give rise to a functional cup anteversion of 28 degrees in standing and 32 degrees in sitting. I have to calculate this manually because I don't have the luxury of the Mako 4.0 like what Corey and the rest of the surgeons have. And I want to aim for a combined anteversion not more than 40 degrees for this patient. I chose a posterior approach because there's a risk of anterior dislocation, and he might need extensile approaches if he's stiff, and I'm more comfortable with that. And I'm going to use a dual mobility, and I chose to use a Mako robotic assisted because it gives me a reliable cup placement as I plan it to be. So that's the planning X-rays where you can see the pre-op is shorter by about 15 mm. I plan for this patient to have a cup that's 54 mm in size and dual mobility with a size 5 accolade stem, giving rise to about a 2 mm shortening. I just pay attention to the X-ray, the left side where he had his left total hip replacement. I find that the offset looks a little bit too much for me. So I will just, for the offset, I'm just comparing with his pre-op. And that's the plan for his cup. And we plan for 45, 26. And we know the femoral version, which is lesser, which is about 5 degrees. So we went on with a femoral first approach, did the femur, did a guided neck resection, and we got the broach version to be about 13 degrees anteversion. And this gives us a rough plan together with your planned cup version, what is going to be your planned combined anteversion of about 39 degrees, still within my 40 degrees of maximum combined anteversion. And we did the cup impacted, and then we do a final cup reduction assessment. We find it to have an inclination of 43 and 25 degrees anteversion. And that's the reduction results, whereby managed to reduce the leg length to equal. And that's his post-op X-rays with a dual mobility liner on the right side. So this is a 6 weeks old post-op clinical pictures. He had NSAIDs 6 weeks for heterotrophic ossification, HO prophylaxis. His FFD is much better. His leg length is restored. And that's him at 1 year. Just saw him recently. He's happy with his ADLs, activities of daily living. He is able to ambulate much better. You can see that he's still unable to put his head down because of his cervical and thoracic kyphosis. And his gait is much better. So a bit of literature on patients with ankylosing spondylitis undergoing total hip replacement. Multiple studies have shown there's increased risk of total hip replacement implant breakage, increased risk of dislocation, increased risk of revision. Long-term survivorship can be similar or slightly lower. And there's obviously increased risk of heterotrophic ossification. Quoting from this paper, some of the summary considerations you have for patients going for total hip replacement include a multidisciplinary approach with a rheumatologist. You want to have the TNF-alpha stops because of risk of infection. General anesthesia is generally chosen for this patient. However, it's also challenging because of the cervical kyphosis and pulmonary restriction. Spinal anesthesia is obviously impossible. Perioperatively, positioning for the patients for total hip replacement can be challenging. And there have been case reports of traumatic paraplegia with hyperextension of the immobile spine during total hip replacement. And there's obviously high risk of HO, and prophylaxis is recommended. Technical considerations. So quoting Professor Wang's paper about which, if you have a spinal deformity or total hip or a hip problem, which one to go first? And it would recommend the spinal deformity up to go first than the total hip, because this will lead to lesser risk of late dislocation. If the hip is done first, then the spine deformity is performed. There is exaggerated posterior pelvic tilt and therefore anterior dislocation in this group, in this unique group of patients. Therefore, you want to consider reducing the anteversion and inclination for these patients. And they can have also bilateral hip involvement, such that if you do manual implantation of the cup, because of the fixed adduction or abduction of the pelvis itself, you can judge your inclination of your cup error. You can have error in judging your inclination of your cup, depending on which position it is, and therefore consider the use of robotic to help you. You can have stiff or even fused hip in severe cases, and you might need to perform neck cut in situ and soft tissue releases extensively. Cemented or cementless implants appears to work well. Summary: ankylosing spondylitis patients present with unique spinopelvic problems and challenges in proper implant positioning. They have a stiff spine problem, yet they also have a progressive kyphosis problem, which is very difficult to plan in advance. There is a requirement for increased functional acceptable anteversion to avoid anterior impingement while sitting, but that also puts them at risk for anterior dislocation while standing. Important parameters are changing. It has been described multiple times: the change in sacral slope, standing anterior pelvic plane, lumbar lordosis, and PI index. And the telltale signs of an exaggerated posterior pelvic tilt is that of an outlet view in the AP X-rays. Functional cup and stand positioning is key to optimal recovery for these patients, and dual mobility and robotics is useful. My Mako 4.0 is coming tomorrow, and thank you.
All right, Corey, you got to get some stamps out now.
What's that?
You got to get some stamps ready. Send off a lot of 4.0s over to Asia.
Oh yeah. No, it's guaranteed. It's on its way. Dr. Tan, is that right? Did I understand you correctly that 4.0 is being released where you are soon? Yes?
Tomorrow.
Yeah.
Tomorrow. Finally. Well, I was hoping for this to have this software when I was doing this patient, obviously, because I had I've gone to some of your talks, and I think it will be totally appropriate for this patient. Well, it is what it is.
Dr. Calendine,
Yes,
can I ask you, this is actually a little bit conflict of interest, but you are the consultant for Stryker company. So I would like to ask you to the headquarters of the Stryker to make a ceramic liner for, Trident cup, because, China and Korea, we have a lot of 40s and 50s of avascular necrosis. And, in an internet, many doctors advertise the ceramic liner lasting more than 30 years, and, comparing to, highly cross-linked poly. So patient wants to ceramic on ceramic bearing. And that people, 40s and 50s, also wants to the good candidate for, robotic surgery. But, the Mako only used for Stryker cup, but they have no ceramic liner. So that's one big obstacle for me to application of the Mako technique for the young AVM patients. So please, Dr. Calendine, ask the
yeah, thank you. I will absolutely share that with them. I'm pretty sure I've been blocked from most of their emails, so that they may not respond. But I think it's a good point. For me, highly cross-linked polyethylene on ceramic, that's my kind of go-to here. And it's been a powerful tool for me. We don't have our current high cross-linked out 10, 15, 20 years, but if it stays below the osteolytic threshold, obviously that's kind of what we do now. And I'm sure that's what you do now as well. Stryker in particular has had a history with some squeaking of the hips with their metal alloy that they use with the Accolade 2. I imagine they'll be hesitant, my dear friend. But I will relay that, and I would just add, I think it should be Delta ceramic when it's done. So
thank you very much.
Dr. Ling, I'd like to share, if you really want to use a ceramic liner, still you can utilize a Mako. You can use the Mako to ream, and also use the Mako to position the trial. And also you can utilize the probe to use its navigation function to position a shell with a ceramic liner. It's still very helpful.
Thank you. That's a good point. I do have to say that would be off-label. But yes, there are people that are using that as a guidance system and a acetabular bone preparation. One other thing that I would add is with all these systems, at least the ones that require preoperative imaging, the preoperative planning piece should not be downplayed or understated. It's a powerful portion of the platform.
Dr. Ling, the good news is many robotics is going to market other than Stryker is in China. Maybe we're going to Korea.
It's totally true. Everybody wants a piece.
Yes.
This conference is going to be too commercial. I'm sorry.
We're supposed to be neutral. It's okay. We're supposed to be neutral.
Well, I do think it's an important point. I would tell you where I think we are in the robotic space is not where we need to be. I love the fact, yes, I disclosed openly that I'm a consultant for Stryker, but obviously internally we're working on the next thing. And to see Velis and Depew and Smith and Nephew Corey in our world, some of the cool things I think that Corin is doing, both on the hip and the knee side, robotics really, we're just scratching the surface. So this this is an interesting time. And I would invite everybody to use not one system, but multiple, robotic and navigation, because I think that's really how we're going to learn.
Well, because I usually talk about technology and not about surgery, which is unfortunate, I can tell you that you're going to see quite a few next generation implants now that don't have a robot. It's all augmented reality. And there was actually a very nice little system at AAHKS this year where you simply visualize where the reamer should be, and you just lock it into that position and go. And these are navigation systems. They're not robotic. So the difference between a navigation system and a robot is that a robot has an actuator. It has a built-in something, a saw, a drill that does something. Whereas a navigation system will align a cutting block, and then you have to pass a saw through it or a drill through it. And so that's a subtle difference in robotics and navigation. And what you're going to see is people trying to get away from the expensive robots and get back to a more simplified form of navigation. And it's going to be up to companies like Stryker, the Pewds, et cetera, to prove that the additional value of the haptics and of the actuator, it's called, are actually worth the cost. And full disclosure, I'm also a consultant for Stryker, but it's a big challenge. And there's, I was said by Dr. Hay, there are a lot of people working in this space and bringing new technologies to the market. It's going to be a very exciting decade, I think.
No, I agree with you, Stefano. It's basically smart instruments and technology. It's the same thing as our phones, we used to have GPSs in our cars. Now our phone is our GPS. So it's everything will be smart instruments in some way or another. I think robot is just a general word. I don't think we're going to connect our patients to something in the room. I don't think surgeons and orthopedics want to do what the Da Vinci does in general surgery. I think we like holding our instruments, so we just want more advanced technology in our instruments.
So let me push you back a little bit. Their time will come where people will not want you to hold the instrument because the robot's more accurate than you are.
I'll be retired, I hope.
We will not be retired. I might be. I'm older than you. Yes, it's a fascinating time, but you're absolutely right. The accuracy, the cool stuff that's happening with AI with 2D to 3D image resolutions. So you get two plane films, create a three-dimensional image that's actually it's going to pretty quickly be as accurate as a CT scan. You'll be able to create three-dimensional models taken of people moving in two planes. So we get away from the seated X-ray and move towards a dynamic view of people's gait and plug that into your robotic arm and get you the right positioning, as opposed to fixed static positioning, which we're accustomed to. There's so much interesting stuff that's happening that I think none of us will recognize the early 2000s, 2020s in about 240. It'll take us 15 to 20 years, but it's amazing. The last thing is how we're going to pay for it. I'm not sure exactly, but it'll be there.
Right. Is there any other questions from the audience or any from?
So Calvin just asked you a clinical question. So why did you choose to use an anti-inflammatory instead of radiation therapy? 400
I was concerned about a wound.
Have you ever? Yeah, it's just, I don't know, I've been doing rads for a long time. I don't think I've ever seen either or published any area concerned about the wounds or infection. And so what happens with NSAIDs, it's interesting. NSAIDs delay calcification of osteoid. They don't prevent the deposition of the osteoid. So even though there's a decrease in calcification of that with NSAIDs, the only way you really can absolutely be certain you're not going to get heterotopic ossification in these patients, especially if you're going in to resect heterotopic ossification, is to irradiate it. NSAIDs are, they can recalcify later. So
I would say I'm fortunate not to manage too many of these heterotopic ossification prophylaxis kind of patient. I've been fortunate to see them working well with NSAIDs and etc. But certainly I take your point.
You did a great job with that. Fantastic work.
Thank you. So your opinion is radiation actually is totally fine, right? Even in the first 2 weeks of...
rads within 24 hours, either before or after surgery. Been doing it 20 years. It's not been an issue. And anytime you're trying to prevent topic ossification, you have to trust your radiologist. They don't irradiate your socket and your stem, right? It's got to be just the soft tissue in between. But so long as they're aware and they know what they're doing, they'll do a good job. And it's very reliable.
I'm curious if others, instead of the radiation, when they use anti-inflammatories, all of my patients get Celebrex now or some anti-inflammatory after surgery. I wonder how that plays in. I got to say, I still radiate if I know they're high risk, like ankylosing spondylitis. But, we're covering all these patients now with anti-inflammatories. What are other people doing? Are other people radiating?
Sorry, in regards to your question, actually, I went to do a lit review. Celebrex works as well as the conventional Indomet for prophylaxis. It's just that, usually the hip patients are not that painful. You don't really need to give them an extended duration. But purely for HO prophylaxis, I give them up to 6 weeks.
I'm radiating much less than I used to. I still think it's
Sorry, we can't hear you guys. James, go first.
No, I'm just saying I'm radiating much less than I used to because of the evidence for anti-inflammatories and because we're using them. And even the aspirin we're using for VT prophylaxis has been shown to decrease HO. So I'm really only radiating the patients that I really think are significantly higher risk, particularly if they've had significant HO on the other side or something along those lines.
Agreed.
Chang, you want to say something?
Yes, I don't think there is a high rate of the ossification in Asia people. So I did a lot of the inflammatory patient, such as the ankylosing spondylitis, but I didn't use the radiation for them. For the result is no ossification occurred. So I don't think this is a high rate in Asia people.
Joe, any experience as well?
I would say heterotopic ossification is quite common for our AS patients. However, the type 4 or even type 3, according to Brooks' classification, is pretty rare. But type 1 and type 2, the incidence is pretty high.
But we also always use the NSAID, the drugs for after operation. Maybe this can have an effect.
Mm-hmm. Oh, we had a very wonderful session with all the distinguished speakers from the first half and the second half of the session. Shall we proceed for the closing speech by Dr. Nicola?
Oh, just 1 second before you do that. I was thinking, as I started, when I was the chairman of the International Committee for AAHKS, which I also started these partnerships, these combined meetings, and it was so great to be invited back and to see how well these are happening between our society and other societies like yours. And I think it's a testament to the comradeship that we developed between ourselves as professors. And I think it's fantastic. I absolutely love the opportunity to have these conversations. I always learn so much, and both from everybody on the panel. I love this repair of the posterior capsule. We learned a lot about it. Everything's been great. The iliopsoas, I've never seen that image of the iliopsoas going over the rim that Dr. Lim showed us. That was a clever way to image the iliopsoas. So it's just been terrific. So congratulations on putting on a great meeting, and I'm just super thrilled. It's great.
Probably, Dr. Lin, you can use the concept of PFA. So PFA indicates how the hip extends. So probably PFA indicates how the iliopsoas tendon stressed.
Thank you, Dr. Zhou. Yeah, I personally email you for the discussion. Yeah, a little bit hungry. Yeah, and the other guys are a little bit sleepy.
Mako is the president of Asia.
Dear friends and colleagues, I'm Nicholas Budi Parama from Indonesia. I'm the current president of Asia. I hope that you have enjoyed the last 3 hours of co-branded seminar between the ASIA-AAHKS, Asia, and the CCOS on the leg length discrepancy and stability. I would like to personally thank all our esteemed faculty for taking time out of their busy schedule, either in the morning or at night, depending on where they are from, to share their valuable knowledge and experience with us. All their presentations had been stellar and the discussion were quite engaging. Our deepest gratitude to Joseph Kerr, the Deputy Executive Directors of the AAHKS, who play a huge role in engaging for AHKS surgeons to be faculty of this seminar. I would also like to thank all of the organizing and the IT team for their hard work to make all this happen. It's a great job, guys. Last but not least, I would like to thank all the participants of this seminar, since without you, we would not have been here today. Asia and AAHKS have had a long history of collaborations since Asia was founded in 2013. I myself have been a member of the AAHKS since 2005. So I hope this partnership will continue to flourish in the future with more co-branded events or combined meetings. Next year, we are hoping to welcome you all to the Asia annual meeting during the Hip and Knee Summit, which has been planned for August 23rd to 26th to 2022 at the Bali International Convention Center. So please make sure to save the dates in your calendar and watch for more updates on our website. Bali, being #1 destination of choice in the world, is ready to welcome you and your family to its paradise after such a long travel restrictions due to the COVID. So please continue, keep safe and healthy. With the holiday seasons coming up very soon, I would like to bid you season's greeting and wish you all a great rest of the year and a wonderful 2022. Thank you.
Thank you. Bye-bye.